We are live now, sir.
Okay, thank you. Dear friends, good morning to all of you. On behalf of myself and Tamil Nadu Ophthalmic Association, I extend a warm welcome to all of you, especially the chairperson of the today webinar on retinopathy of prematurity, Dr. Pramod Bende from my dear friend Sanganesralia, and the moderator of the session, Dr. Paraksha, Dr. Sayyid Moedin, and Dr. Rajakumari, and the eminent speaker of today's webinar, various institutions having so much of knowledge in the field of recovery prematurity. Especially, I welcome Dr. Srinivas, a neonatologist from KMCH, Coimbatore, and our own ophthalmologist from across the state, Dr. Renu Rajan, Dr. Balasubramaniam, and Dr. Janani Srinivasan, Meenakshi Swaminathan, and of course, other Paraksha and Sriram Gopal, and also the other members of the managing committee of TNOA, Dr. Prasanna, and other people extend a warm welcome to all of you on behalf of myself and TNOA. All of you very well that the theme for the current year of TNOA is the synergy through unity. Just together we can. With that, we with the support of all the members of the TNOA and all the institutions, both the governmental and the non-governmental organization, we are doing a lot of academic activities to make awareness about the various types of eye diseases and also what are the available latest technology in the field of ophthalmology. We are organizing various webinars from across the faculty from across the state, and also every month we are having a guest lecture from one of the international faculty which in the respective field as the retina, cornea, something like that. And also last month we had a midterm Tamil Nadu Ophthalmic Association at Kuttalam, which was a wonderful meeting, and it was a nice get together of all the most of the well attended. I'm very happy that many people have enjoyed their stay at Kuttalam, and really I'm very happy. So with this today webinar, of course, on ROP is actually wanted to have it last month itself. So I informed my friend Dr. Parag and Sriram Gopal to, because they are, Parag is one of the leading person who is doing screening for ROP for quite a long time. And of course, nowadays, many of the private, non-governmental, as well as the government hospitals are doing extensive screening in the field of ROP, because ROP is one of the important causes of the childhood blindness, preventable childhood blindness. And of course, now with the advancement in the field of neonatology and gynecology, now the survival rate of premature infant is so high. So automatically the children with ROP is also on the increasing trend. So early recognition, early diagnosis, and early intervention is one of the current important thing in preventing the blindness from the this condition. So to make awareness about this, one of the important thing in the, especially in the infants, premature birth, we thought of organizing this wonderful CME. So in that event, I have to thank extensively my dear Dr. Parag and also the Sriram Gopal for having a wonderful speaker, and also definitely it will be useful for the practicing ophthalmologists to update their knowledge in the field of ROP so that they can diagnose ROP early and refer them or treat them early so that to prevent them going for blindness. So once again, I welcome the chairperson, Pramod, and also the moderator, Paraksha, Sayyid Moideen, and Rajakumari, and also all the speakers, and also all the ophthalmologists who are attending this webinar. Definitely, it will be a wonderful webinar, and also we are expecting a lot of things to learn from this. Thank you very much. I hand over the mic to Dr. Paraksha to move it forward. Parag, yeah.
Thank you, sir, and thank you for this opportunity for this sort of rare disease of ophthalmology. Not many people do it, and only now recently it's coming in the forefront. So I thank the TNOA for giving us this opportunity. So I welcome all the chairperson, the moderators, speakers, and the audience. And let us start with the program. So the first talk is on pathogenesis and risk factor for ROP. And we are lucky to have our neonatologist from KMCH, Dr. A.R. Srinivas, who is quite passionate in doing doing his work and preventing. I've seen him, how he works. And he's a neonatologist who's trained in Australia. He was working there, and he's joined KMCH. And just a short word about him is like, I always tell him that his NICU is a very bad NICU for us to teach ROP, because we don't see any ROP in his NICU. So in that way, that's a thing that the way neonatologists should work, because that is where the primary prevention comes. And you can easily follow the US, UK guidelines in his NICU. And it's one of the best NICUs in Tamil Nadu and India. And we do so much of screening, but we don't see any ROP. So I really thank him for being here and give his talk on the pathogenesis and risk factors for ROP. Over to you, sir.
Thank you. Thank you. Thank you very much, Dr. Parag. That was a very nice introduction. Can you hear me? Hello?
Yes, sir. You're audible, sir.
Yes, doctor.
Okay. Okay, thank you. Thank you very much. That was a very nice introduction on our NICU and us. And we do take care of babies from 24 weeks of gestation, and we do have a very less amount of ROPs which are seen. Every year we get about 1 or 2 cases who go on to stage 3 requiring laser. And I don't think we have lost any babies with the eyesight. So that's an excellent work. We deal almost about 100 extreme premature babies less than 27 weeks every year. And still our incidence of ROP is very less. Now quickly moving on to the pathogenesis and risk factors of ROP. I know there are all eminent ophthalmologists here. Probably I'll be a bacha here in ROP. I'll try to convey whatever I could understand with this pathogenesis. So these are the contents, briefly, what is ROP and history of ROP in relation to pathogenesis, risk factors for ROP, and again a pathogenesis of ROP and aggressive ROP, and some evidences in relation to the risk factors and pathogenesis. And please inform me if I'm overshooting. I'll have a look at the watch also. So ROP generally for us ophthalmologist and pediatrician here in neonatology, we know that it's a vascular proliferative disorder. It occurs in the retina of the preterm infants, especially with incomplete retinal vascularization. And it's a very important cause for severe visual impairment in childhood, especially in premature babies. On the right side, if you look at, you can see a picture on the retina of a full-term baby and retina of a premature baby where the vasculature is not complete. And this is a picture showing the detachment of retina in very severe ROPs. So coming to the history of oxygen use in preterm neonates, because this was a very important idea which gave everyone what exactly was causing ROP. In 1940s, in some studies, they found that they were all observational studies. When the babies used to have a lot of apnea, they were cessation with the breath. And when they gave oxygen, the breathing became very regular. And apnea was prevented when they gave high oxygen. And you can see these graphs. So whenever oxygen was commenced, the periodic breathing became more regular. And this is how oxygen in premature baby became very prominent and very popular. And subsequently, they started using liberal oxygen. Even some of them used even hyperbaric oxygen to prevent this apnea. And subsequently, in the next few years, they found that there was a significant increase in incidence of ROP. At that time, it was called as retrolental fibrplasia. So in mid-1950s, oxygen was implicated as the cause of this increased ROP. So NIH sponsored a multi-center trial where they used routine oxygen and curtail oxygen to treat babies less than 1,500 grams. The result was really conclusive. Rate of severe ROP reduced by almost 2/3 where there was a curtailed oxygen use. And subgroup analysis also showed that it was the period of oxygen use. The longer the time you use oxygen, there is a higher chance of developing ROP. These are some of the epidemics of ROP. Again, this gives us useful information about the pathogenesis. The first epidemic was when they started using high oxygen, and they noticed a second epidemic even after curtailing the oxygen. That was when there were a lot of extreme premature babies started surviving in Western countries. And therefore, these extreme prematurity was one of the cause for more ROPs. So this gave us an idea that more the premature babies, the more chance of ROPs. And then again, in late 2000, there was a third epidemic when all the developing countries started having increased incidence of ROP. And that was because there was a better outcome. They were surviving, but not with the quality. So they used to save the babies, but there was no quality care. And therefore, the incidence of ROP significantly went up in this institution, especially in the developing areas. So again, coming to the epidemiology or incidence of ROP, substantial number of preterm infants are affected worldwide. The lower the gestation, higher the chance of developing ROP. Lower the birth weight, again, higher the chances of developing ROP. So a lot of multi-center trials were done. Incidence of ROP in preterm births was proportional to the gestation. Lower the gestation, there was significantly increase. So in babies less than 1,250 grams, the incidence of ROP was almost 68%, but now it has again significantly come down because of advanced care. At that time, the overall incidence was depending on the gestation. If they were more than 32 weeks, the incidence was 8%. Now in developing countries, it's almost nil. If they are more than 32 weeks, developed countries, and in developed countries, we still have this incidence of ROP even in babies more than 32 weeks. And again, between 27 to 31 weeks, there is a 19% incidence of ROP, and less than 27 weeks, it's more than 43%. So lesser the gestation, more chances of developing ROP. Just some of the pictures are masking. Can I slow down? Okay, thank you. So emerging epidemics of ROP in India, because there are a lot of preterm births everywhere in India, and they are surviving because of some care, but they don't have quality care. There is mushrooming of these NICUs with poor or substandard preterm care. So this has led to improved survival of preterm due to increased neonatal services, but substandard treatment. So lack of appropriate knowledge and awareness among these caregivers is one of the causes for these increased incidence of ROP. And these people or doctors and the nurses, everyone require a proper training to manage these babies in a more quality way. And we will touch upon what are the important things which they have to be aware before treating these extreme premature babies. And in general, incidence of ROP in all preterm babies around 20 to 30% in screen neonates in India. So now again, premature babies, they are more susceptible to oxygen-induced toxicity. Why are they more prone? Because antioxidant system develops only in the last trimester or the third trimester. Hence, these premature babies lack antioxidant. So hence, this leads on to free radical, which damages the enzymes, hence decrease the protein synthesis, decreases the DNA synthesis, and also decreases surfactant production, bringing in more complications for these babies, causing more damage to the eyes. In general, in this, I've got a summary of all the factors leading to ROP. There are more than 50 factors, but I've touched only on the common factors. The one which is shaded blue, they are the most important ones. That is oxygen use, fluctuation in saturation, and duration of oxygen use. On the other side, you have got the prematurity, extreme low birth weight babies, and fetally growth restricted babies. These are the people who are, or babies who are more prone for developing this ROP. The other causes are listed here: hypoxia, hyperoxia, hypotension. In fact, anything deviation from the normal can lead on to increased incidence of ROP. On the right side, you have got, if babies are received antenatal steroids, the chance of ROP is less because these babies are generally more stable after delivery. And light, though evidence is not very strong, but there is a tendency, if there is a bright light exposed to these babies regularly, there is a tendency for increased ROPs. And overall health of the infant is what is more important. It's not one particular factor, it's the multiple factor which causes ROP. So this explains the importance of multifactorial etiology for ROP. So you have got on one side the prematurity and the low birth weight. On the other side, you have got the unmonitored oxygen supplementation. And the third side, you have got the poor quality care. So all combined only will give an incidence of ROP and the severity of ROP. So all three factors have to be taken care by decreasing prematurity, by controlling oxygen use, and giving a quality care for these babies. So this just an example with respiratory support, what are the problems which can cause. So you have got all these traumas: volu trauma, barotrauma, oxytrauma when we start on ventilator or CPAP, even atelectotrauma, biotrauma, and rheotrauma. So most important is, of course, oxytrauma, because if you give too much of oxygen, this is going to cause more incidence of ROP. So oxygen is called as a silent killer in NICU because we think these babies are saturating well and they're doing well. But if they are saturating more than 96, 97%, every organ is damaged, and the major target will be the eyes where the ROP develops. So now we go on to the pathogenesis. Before going to that, a normal vascularization, 1 or 2 slides. So no blood vessels are generally seen in the retina less than 16 weeks of gestation. At that time, the vascular supply is mainly by the hyaloid artery, and that supplies the lens and helps in the growth of these eyes. 6th week, anterior segment of the eye receives its vascular supply from the hyaloid artery. This artery extends from the optic cusp, passes through the vitreous, and supplies vessels to both surfaces of the lens and iris. These vessels generally, they disappear by 34 weeks of gestation. By that time, the normal blood vessels starts appearing. Retinal vascularization starts around 15 to 18 weeks. Retinal blood vessels extend out from the optic disc and grow peripherally. And vascularization on the nasal side is complete by 36 weeks. And on the temporal side is completed by around 40 weeks. But in preterm babies, maturation may be delayed even up to 48 weeks or 52 weeks. And this is the reason where we have to follow up these babies for a longer period once they start developing signs of ROP. So coming to pathogenesis of ROP, one of the most important things which we should remember is the fetus. When the fetus is in utero, the PaO2, partial pressure of oxygen, is only around 20 to 60 millimeter of mercury, averaging around 40 millimeter of mercury. And saturation is around 60 to 90%, averaging around 70% of saturation. So these babies, example, an infant born at 28 weeks of gestation should have been physiologically hypoxic till it reached around 40 weeks. But soon after birth, these babies are subjected to high oxygen. There is a relative hyperoxia, and this causes changes in the eye development, which leads on to decreased VEGF, it is vascular endothelial growth factor, and then we start the phase 1 of ROP started there. So this generally happens in babies less than 32 weeks of gestation, where the vasocessation happens. And then in phase 2, after 32 weeks, there is a relative hypoxia because of the rapidly developing retina, and this increases the vasoproliferation. And then subsequently, there is a regression, and cicatrization leads to ROP classical. So coming to this, how exactly it happens, pathophysiology. So normal or abnormal vascularization depends on the regulation and expression of VEGF and IGF, erythropoietin, and also omega-3 polyunsaturated fatty acids. Even a lot of other cytokines are involved in this, which will contribute for the development of ROP. The mechanism for what disrupts and what follows in pathogenesis is really unknown. Still, a lot of things has to be understood. So major contributors are insulin-like growth factor. This supports normal retinal vascular growth and also interacts with VEGF in developing the normal vasculature. So here in this picture, you can see this is the normal vasculature development. On the right side, you have got the abnormal blood vessel growth, where there is excessive vascular growth or proliferation. In summary, for this pathogenesis, here premature infants are exposed to higher oxygen as soon as they are born. This leads to hyperoxia, which down regulates the VEGF and IGF. It leads on to vasoobliteration and constriction. Therefore, there is vascular depletion, but retina continues to grow because the vascular bed in the choroid, it continues to supply blood to the retina. But at one stage, because the rapidly developing retina, the oxygen supplied by the choroid bed is not sufficient. So this becomes hypoxic, and this induces the increased metabolic demand and triggers the vasoproliferative phase. And this leads to overproduction of VEGF and IGF-1. Therefore, there is increased proliferation, dilatation of the vessels, lot of proteins start leaking in, which lets the gel, which is sticky, and this sticks on to the retina. And once this gel starts constricting, there will be traction on the retina, which leads to bleeding and retinal detachment. And critical stage of ROP generally occurs around 33 to 34 weeks of gestation. So this is pictorial representation of the pathogenesis. If you look here, this is the normal vessel growth. And here in premature birth, there is decreased IGF and VEGF, leads on to starting of the ROP. And then with the maturing retina, there is increased IGF and increased VEGF, and this leads on to proliferation and then retinal neovascularization. If properly controlled, if all the factors are taken care properly, the vessel growth becomes normal and there is resolution of ROP. But if not controlled properly, there is a proliferative retinopathy, which leads to retinal detachment. And here we have got different stages of ROP. I think you're all eminent ophthalmologists, you should be aware. So I'm not going to the details of this. So just one slide about the early aggressive ROP. It's an aggressive posterior retinopathy of prematurity, previously called as type 2 ROP or the rush ROP. This is characterized by severe plus disease, flat neovascularization in zone 1 or posterior zone 2, intraretinal shunting, hemorrhage, and a very rapidly progression to retinal detachment. And this is one of the worst type of ROP where the prognosis is not that good if it develops. And classically, this develops in very extreme premature babies who are not taken care of properly in the initial stages. Probably these slides, I'll just click this regarding the treatment. I think we have got speakers on treatment. Only thing, future strategies are antioxidants, anti-inflammatories, modulators of metabolite signaling, growth factors, omega-3 polyunsaturated fatty acid, and also stem cell therapy are on the list. So just last few slides, I'll just highlight the evidences. So incidence of ROP is high in premature babies. This was study in Canada. You can see there is some disturbance. Hello. So in extreme premature babies less than 24 weeks, there is a higher incidence of stage 3 ROP. So this is clearly evident that lower the gestation, there is a higher chance of ROP. And again, this tells us lower the birth weight, the chance of getting ROP is quite high. In babies less than 750 grams, the incidence of stage 3 ROP is almost 29%. And as the weight increases, incidence of ROP comes down significantly. So again, these were different studies where they quoted the incidence of ROP. In the ATROP study, they reported about 82.5% incidence. Cryo ROP study, they reported 81.6%. Lawrence et al. In his study reported 62%. Kumar et al. Reported 32.8%. And Zinn et al. In a multi-center trial study reported around 62%. Overall, in babies less than 1,000 grams, we have got ROPs around at least around 40 to 60%. This is again, whenever there is some complication in these babies, we have other complications. So if there is increased incidence of IVH, intraventricular hemorrhage in these babies, there is a higher incidence of ROP. Here you can see in stage 3 ROP, there is much higher chances of having a significant grade 3 or grade 4 IVH. So higher the complication in babies, there is a higher chances of developing ROP. So this was a landmark study which was giving a lot of new information. Probably more studies are being done. Subsequently, this may be introduced in the NICUs because The initial studies are favorable to this. So this is a graded, I think I'll not read that slide, sorry. Okay, sorry, I just missed that. One more slide where they thought that intermittent hypoxemic episodes in these babies increases the incidence of ROP. So if baby is fluctuating more, it's not only the fluctuation of saturation, fluctuation of BP, fluctuation of CO2, everything increases the incidence of ROP. This is one study which shows if there is improved fluctuation of the oxygen. So example here on this side, you have got number of fluctuation per week. If the fluctuation are more, the incidence of ROP also goes up. So fluctuation in oxygen saturation, BP, CO2, everything has to be prevented to decrease the incidence of ROP, and this has to be concentrated. So delayed cord clamping has shown a tendency towards decrease in ROP. Example, they did a study where they delayed cord clamping for 30 to 45 seconds and 60 to 75 seconds after birth. A delayed cord clamping showed an evidence that it could be useful in preventing ROP. And now I come to that study which I was mentioning. This is graded oxygen saturation targets and ROP in extreme preterm infants. This is what a landmark study where it's giving a lot of useful information where more ROPs can be prevented with decreased incidence on outcome, that is final death or morbidity. So now currently if we target high oxygen, ROP incidence is less, but we end up in having more morbidity. Even low oxygen ends up in having higher incidence of ROP, and also the morbidity and death also increases. By this graded oxygen saturation targets, probably all these problems could be decreased, but we need more studies on this. What exactly they did was, group one was, it was an ad hoc study from 1995 to 2001.
So you have
target saturation. Just one or two slides.
Okay, sir. Thank you.
Saturation was targeted between 90 to 94%. And after that, in 2003 to 2010, they targeted in graded way. Initially, they targeted between 83 to 89% till around 32 weeks, 90 to 94% till 35 weeks, and more than 94% after 36 weeks. The result was really conclusive. So they found there is a significant decrease in severe ROP, and there was no difference in mortality and morbidity. This is what is important. This study is giving a lot of useful information. If we get good multi-center trials, that graded oxygen saturation will be useful without increasing the mortality. Probably that will be really useful in decreasing the incidence of ROP. Take-home messages: prevention ROP is very crucial in NICU care. Educating regarding oxygen use is extremely important. Oxygen may lead to acute or chronic health effects. ROP is a major effect in this, and neonatal exposure to pure oxygen, even if brief, should be avoided. And pulse oximetry more than 95% when breathing supplemental oxygen must be avoided as per the current evidence. And pathogenesis and risk factors of ROP are multifactorial. Thank you very much.
Thank you, sir. It was a wonderful talk. And like you said, prevention, it is in the neonatologist's hand only, and the primary prevention is more important, and we come only in the secondary and the tertiary prevention of screening and treating. So thank you very much. Any questions from the group here, the panelists?
Yeah, Parag, I have one question here.
Yes.
I think it's a very excellent talk, and I think we also learn a lot. Antenatal steroid, what is the role? I think if I missed or something, sir has already spoken.
Yeah, no. Antenatal steroid, the advantage is it's not a direct effect. When the baby receives antenatal steroid, we have less complications in babies. Example, there is a decreased incidence of respiratory distress. There is decreased incidence of all the complications like IVH. So in net, we get an outcome that ROP incidence also significantly comes down.
Okay. Thank you, sir. Thank you very much.
I just have one point. I really like that last line which sir said about maintaining SpO2 of less than 95. But unfortunately, sir, with NICUs springing up in every nook and corner, I think unfortunately that is, especially in these new NICUs, which spring up in any damn place these days, this is not being followed. What best can be done to implement such a protocols from your side? From a
I do agree, sir. I do agree. I get a lot of cases being referred from Arvind Hospital for this thing fitness. I feel so sorry, even babies 34 weeks, 36 weeks, 32 weeks, who are very well to do and 1.5 kilo or 2 kilo at birth, developing severe ROP, that to stage 5, and they lose their eyesight. And this is one of the reasons I strongly condemn any level 2 NICUs treating extreme premature babies, because there is a real lack of care, because nutrition also forms a major role. Not only oxygen, ventilation, nutrition also has to be taken care. We in our NICU, every baby receiving oxygen has to be SpO2 monitored. That is compulsory. That's what we have introduced in our NICU, and we take care of nutrition for all babies. And this is one of the main reasons why our incidence of ROP is significantly low.
Yeah, probably also because we had a Paragood, no, actually we had the ROP task force set up by Ministry of Health. They also put up some guidelines when you set NICU, the minimum criteria has to be followed. Of course, we all have laws, rules, regulation, implementation is the issue overall. I think that's the main problem what we have. There are regulations that when you set up NICU, I think now there are guidelines, they are supposed to be comply with that.
True, sir.
So can you stop sharing your screen, sir?
Yeah.
Thank you, sir. That's a wonderful talk. Now I call Dr. Paraksha sir for giving us a classification of ROP. He completed his DMD from Madurai Aravind, and then after that he did his fellowship from Aravind Coimbatore. Thereafter, he is grown up from a junior consultant to he is now heading the pediatric retina department. His field of interest is mainly ROP, ocular oncology, and tumors. And we are fortunate enough that he is one of the international committee member for the revised ICROP guidelines. And over to you, sir, for the ROP classification.
Thank you very much, Said. So the classification of ROP was, the ICROP was first published in 1984. And then it was, the stages were given, stages 1 to 3 with plus disease. The second edition in 1987, when they added retinal detachment 4A, B, and 5. And 2005, it was again revisited to include the pre-plus disease and the aggressive posterior ROP. And recently in 2021, the international classification was revised, the ICROP 3 edition, which was published. And it gave a few more modifications because of the current treatment. The thing is that these are the modifications they came out with: addition of a posterior zone 2. The term notch was introduced. Sample images of a continuous spectrum of normal to pre-plus of plus was given, not a single image, but a spectrum of images. Aggressive posterior ROP was renamed as aggressive ROP. Stage 5 was subcategorized as 5A, B, C. And regression and reactivation are the two major additional things which were added because of the anti-VEGF era. And they've introduced the term as persistent avascular retina. And when it reactivates after anti-VEGF, then you have to put the word as reactivated, whatever stage is there, stage 2, and the introduction of the fluorescein angiography and OCT imaging. But in a nutshell, the classification of ROP is different from other. When you see other disease, we straight away go for the stages. But here you should remember the components of the classification. There are 4. Classification contains of the zones, the plus disease, staging, and the extent in the number of clockers. So this remains the same throughout all the classifications of ROP. So come to the zones with the disc at the center, and the twice the distance between the disc and the macula is zone 1. From the edge of nasal zone 1 to the nasal ora serrata and the corresponding area temporally is zone 2, and the thin strip of temporal retina is zone 3. There is no anatomical landmark, but the 2005 classification gave a practical tool how to differentiate, which I'll tell you later. So the ICROP 3 introduced something called as the posterior zone 2, which is around 2 disc diameters from zone 1. And why they added that? Because it is recognized that the posterior zone 2, disease in the posterior zone 2 behaves much more like a zone 1. It is more severe. So and compared to the anterior zone 2. So if someone writes as posterior zone 2, then it shows that the prognosis is even worse, and it is a sort of a aggressive disease compared to the anterior zone 2, and that is what the ICROP has recognized and introduced this in the recent classification. The term notch also was introduced. We have been already taught that you put the posterior most zone, what you see, and then the worst stage. But sometimes we see that the zone, maybe you can write zone 1, but you see that only 2 clockers in zone 1, where the next 10 clockers are in zone 2. So this is the notch which we see quite often. So if the examiner puts it is a zone 1 secondary to notch, that means only 2 clockers are in zone 1, where the other 10 clockers are in actually zone 2. So the prognosis is a little better of this disease than the disease which is purely all the 12 clockers in zone 1. Pre-plus was introduced in 2005 classification, which is somewhere between normal and the and plus disease. It has got little bit of tortuosity and dilatation, which is a little sort of a gray area, which even the experts don't agree. Some people say it's plus, some people say pre-plus. So this was also recognized by the ICROP3, and that's why they gave a spectrum of images. Plus disease is like dilatation and tortuosity of the posterior polyretinal vessels, and it shows the sign that indicates the severity of ROP. So this is one of the most important signs. If people can just diagnose plus disease, that means this patient will require treatment and have to be treated or referred immediately. And it may or may not be with the engorged iris vessels, pupil rigidity, or vitreous haze. So the ICROP3 gave a spectrum of images instead of a single image. And these are the images that was given to all the experts. And you can see, although the green is everybody agreed as plus, the red, everybody, I mean, normal, red, everybody agreed as plus. But these are the areas where not all the experts also agreed. So we know that it's a different, it's a real world problem of what is pre-plus, what is plus. So they've recognized this, and they've given actually a spectrum of images from the normal to pre-plus to plus. And they have determined that the zone 1, that the plus should be determined within zone 1 and not the narrow field which was given the previous classifications or number of quadrants of abnormality. Now coming to the stages, so there are it depends on the degree of vascular changes, and each stage is defined by its location in zone and the external clockers. So we all know stage 1 is a line which is flat, which is between the vascular and the avascular retina. When it becomes thick, it becomes a ridge, and that is stage 2. And it can have these small tufts of new vessels called the popcorn vessels, or when they fuse, they can be called as the sausage vessel. But this also is stage 2. Stage 3 is when the ridge and there is extraretinal fibrovascular proliferation, as you can see here. This is called stage 3. And stage 4 is the partial retinal detachment, when it is not involving the macula in the periphery. It is 4A, and when it involves the macula, it is 4B, and it is usually is fractional. And stage 5 is a total retinal detachment, which on ultrasound can be subclassified as open, narrow, narrow, and narrow. But then not everybody has an ultrasound in your practice, and nobody can do it in the NICU if you see a baby like this. So that is why the ICROP3 gave this subclassification of 5 as 5A, B, and C, where 5A, you can see the posterior pole, 5B, it's just like a retrolental fibroplasia, and 5C is there are anterior segment changes. So this gives a clinical view of there's a open configuration, this is a narrow configuration, and this obviously is a narrow. So it gives a sort of a prognostic tool for which you should operate, and to give to the parents that what is the severity of the stage 5. Now, aggressive posterior ROP was also defined in 2005 classification, and what they defined is confined to the tiniest babies in their scenario. It used to be called as the rest disease of the fulminate ROP. But now what we see, and what we have published also, and many other groups also have published, that we see aggressive posterior ROP not only in smaller babies, but even in bigger babies. And you can see the mean gestational age and the birth weight of AP ROP in our scenario compared to the West, and it is a drastic difference. I mean, these babies would not have even followed the screening guidelines of the West, and they develop AP ROP. So this was also recognized by the ICROP3, and then they have changed the name of the aggressive posterior ROP as aggressive ROP, and they have put this term as a particular region of the world with limited resources, in a very sort of a diplomatic way, not to hurt the neonatologists. Like what Sriram was saying, and what Srinivasan sir also was saying, that this is where the primary prevention comes. If you have a good NICU with good NICU care, you don't see this disease. We have never seen an aggressive ROP in KMCH hospital, which caters to so many preterm babies, but we see this so often coming from the peripheral centers. So this is the change. The posterior is dropped. So and now it is called as the aggressive ROP. So what are the features? It does not follow the classic stages. It has a fast progression and the poor outcome. And it is quite posterior, just 2 disc diameters from the disc, and just temporal to the fovea, and sometimes even the fovea is avascular, and some people call it the zone half disease. And it has an atypical morphology. Instead of a demarcation line, a vessel is seen, and it skips stages. You can see a flat new vessel, and you wait for stage 1. If you think that you will wait for stage 3, stage 2 to happen, it will just skip, go to stage 3, and immediately there will be detachment happening. And the hallmark is there is severe plus disease, and periphery will look as if it's like a immature blood vessels. And the shunting occurs in the anterior, peripherally in the arteriovenous anastomosis rather than the ridge, what is in the classic ROP. And there's a halo also seen around these vessels. So these vascular proliferation can be often overlooked by a less experienced examiner. So we also recommend that if you are using a 28 diopter, you do use a 20 diopter, and then you'll see these subtle changes much more clearly because it's a higher magnification, and the eye may end up rapidly in retinal detachment and blindness. So coming to the practical tool of how do you estimate zone 1 to zone 2, this was the 2005 classification given. So if you take a 28 diopter lens, and if you keep the disc on one side, then whatever the retina is seen is a zone 1 or posterior zone 2. And if the disc goes out of the picture, then what you're seeing is zone 2. And zone 3 is actually just a very small strip of temporal retina, which is approximately 2 to 3 disc diameters from the ora serrata. Extent of the disease, this is unchanged. This is the same thing what we use in all the retinal diagrams, the 12 clock hours, the right eye and the left eye. And it is the same for the ROP classification also. So regression is one of the key changes ICROP 3 has recognized and recognized and added. It is because of the anti-VEGF era. When we do a laser, it regresses, but then anti-VEGF, it keeps on lingering for a long time, and there is a avascular retina which is persistent for a long time, and that is why they've recognized and they've introduced this term as the persistent avascular retina, called as PAR. And if anti-VEGF, if it regresses and there is a persistent avascular retina, you just have to mention it that there is a persistent avascular retina either in zone 1 or zone 2. That means this patient will require a longer follow-up, because there can be a reactivation, and the reactivation after anti-VEGF can happen anytime between till around 60 weeks and even at 80 weeks also. And when you see a reactivated stage after regression of anti-VEGF, then you have to add this term called as a reactivated. So if someone's reached this in the chart that reactivated stage 2, that means this patient had somewhere previously a stage 3 or an aggressive ROP, was given anti-VEGF. There was a persistent avascular retina, and when the anti-VEGF, the effect reduces, it has reactivated, and this is called as a reactivated stage 2. And these are few OCT and the fundus fluorescent angiography images which they have introduced, and they just wanted to introduce this not for anything else. It does not really help if it's a stage 1, stage 2, or stage 3, and by OCT by changing your treatment. But there is a role in stage 4 detachment. If it's a 4A or 4B, sometimes we think that it is a 4A, but if you do an OCT, the macula will be off, which won't be so obvious clinically, and so it becomes. So this is the only stage which it can help. The OCT can help the our treatment guidelines and the judgment. And of course, the fundus fluorescent angiography also is not that, but then it can help you to identify there is an aggressive ROP and how posterior are the CNP areas coming. So in a nutshell, these are the modifications which have been given in the ICROP 3 classification of posterior zone 2 notch, continuous spectrum of the plus disease. Aggressive ROP has been introduced. Categories of stage 5, regression, reactivation, and the OCT and FFA. So thank you very much.
Thank you, sir. It was a wonderful talk. And still, I think it is still evolving. The classification may be changed in future also. So what is your take regarding the term called hybrid ROP classification?
Well, I think hybrid ROP is somewhere, it's a sort of a evolving, it is a natural history of an aggressive ROP. An aggressive ROP, it comes as flat new vessels, and we have seen that if you wait and watch, you'll start seeing these new vessels coming, and then you'll see the flat on one side and the new vessels on. So this is what is called the hybrid ROP, and then it progresses quickly to stage 5. So I think it is a natural history from aggressive ROP to stage 5 where you see this hybrid ROP in between.
And another term, Parag, smoldering ROP.
Smoldering ROP is something, it keeps on lingering. And like Dr. Srinivasan was saying, it depends on the nutrition of the child also. So if the child has a low birth weight and there is a failure to thrive, if the child is not growing that well, the ROP keeps on also lingering, and there is a smoldering form. So you have to keep for a long-term follow-up. But then smoldering ROP is a natural regression, is different from what you see in anti-VEGF treated eyes. So that is a little more dangerous. Where if it is not an anti-VEGF treated eye, then smoldering ROP is something which you can wait and watch. But and you should tell about the improvement in the nutrition. Tell them to the importance of feeding the breast milk and all that, and tell the pediatrician also that why is the child not growing, because I'm seeing this ROP. Look at the nutrition, and that really helps and makes a change.
And I noticed that you said this persistent avascular retina can last up to more than 60 weeks.
Yeah.
Anything beyond 50 weeks, how do you manage to examine these babies? Do you do a EUA every 2 weeks or 4 weeks, or how do you manage to?
It is a challenge. It is difficult. So some people would not wait for that and just give the laser so they can sleep happily. And but I don't like to sleep happily, so I keep on waiting. And then of course at some point you have to give anesthesia and see. And if at all you're seeing the posterior pole subtle changes like a pre-plus, like a thing, not a frank plus, that is the time you should suspect something else is happening. And even if it's a stage 2 or something, or stage 1, I would not hesitate of doing a laser than waiting. If there's a PAR, I would wait and watch. But if there is some stage happening, then I would prefer doing a laser.
Because we've discussed over the phone many times regarding many patients. This PA, picking up a frank APROP and treating it is not really, when you start doing it, it's not really a problem. This PARs are really a pain in the neck, and they, with or without anti-VEGF treatment, as you said, they keep coming back again and again, and it's very difficult to follow them up and keep examining them. At some point, I think you're really pushed to do the laser at some point.
Yeah.
For me, probably it comes a little sooner than later.
No, that is true. I mean, it's not is a phrase. It's in a true sense, yes, it's pain in the neck and back also, because to examining this babies, yes, I agree. And that's what was Parag said, yes, after 60, because there are situations, even 74 weeks, there are situations, how long you are going to examining and as baby grow is extremely difficult. Eventually, at some point of time, and yes, I agree, subtle changes, you notice that things are like worsening, slight increase in tortuosity or slight increase congestion of the vessel, probably time they treat them off. So I think that's because not only for us, sometimes difficult for parents to bring baby for checkup also becoming an issue, particularly their outstation, traveling and all those issues. I think things are a bit difficult.
And the general dictum goes that once it goes well into zone 3, generally the eyes are safe. We have seen few babies, like I have shared one baby with Parag, where it didn't really hold good also. It was far into zone 3. Hardly you could put 3 or 4 rows of laser and that patient developed macular dragging.
No, actually, that was true when we were looking at a natural course without anti-VEGF. Now, anti-VEGF had changed entire pattern now, whether it is called as ROP, whether it is branch, whether it is vascular occlusion, also what you see, BRVO and all those things. I think entire natural course, we do not know now what the natural cause is. The moment you intervene, I think things are now different. Previously, yes, when no treatment at all, and most of the time you are already zone 3, maybe 1 or 2 disc area left over. I think most of those areas never used to happen anything.
Yes, sir. True.
Right. So let's move to the next talk.
Yeah.
The next speaker is Dr. K.C. Balasubramaniam from Erode, a very close friend of mine, and does a wonderful job as a private practitioner in Erode. And really hats off to all these people like Bala, Sriram, Saeed, working in so passionately in these areas where a lot of people are not interested in ROP screening and not doing, and we require such passionate people also in the smaller cities, and he's doing a wonderful job there. So thank you, Bala, and I welcome you to give your talk on the ROP screening guidelines and imaging.
Can you hear me, Parag?
Yeah, good.
So thanks Sriram and Ramakrishna sir and TNOA for giving me this opportunity. So when I started preparing for this talk, so happy to see PB sir's thoughts put in his guest editorial, so which helped my job easier to talk on this topic of ROP screening. So just to give an idea about the workload or the ROP issue we are facing in India. So globally, about 14.8 million babies are born as preterm, out of which almost 25% is in India. So imagine the amount of screening we have to do if we want to tackle this issue of ROP-induced blindness. So the various causes have been attributed for increased causes for ROP in India, of which one important factor has been cited as lack of uniform ROP screening protocols in India. So how to address this? So can we just follow the Western guidelines? For example, the American Association of Pediatrician guidelines, which says preterm, any baby less than 30 weeks and less than 1,500 grams, you can do the ROP screening. More than that, it's not required. But that is for a developed country. But can it apply to a developing country, India? Answer is no, for various reasons, but two important reasons, as everybody in this panel will agree, that we do see sight-threatening ROP even in more mature babies. When I say more mature, even more than 2 kg, I mean more than 35 weeks, and heavier babies, more than 2 kg. So we do see babies in more than 30 weeks and more than 1,500 grams as given in AAP guidelines. So what do we need is an Indian-centric guidelines. So based on this, 2010, the guidelines were formed by the National Neonatology Forum. Then in 2015, we have the Ministry of Health issuing some more guidelines. But finally, in 2019, we got the operational guidelines from for ROP. This was based on combined input from National ROP Task Force. I think Dr. PB Sir perhaps might be involved in that, and RBSK and PHFI and NPCB. So all the minds were, sat together and brought the operation guidelines, taking into account all the variable factors in India, difference in healthcare, difference in trained manpower, difference in the economic status. So putting all these together, so the operation guidelines were derived, and there's a nice article. Anybody who's interested or watching this talk, you can Google this and go through this article. It's an excellent article which summarizes all the issues for if one wants to get into ROP screening in India. So it basically laid down the screening criteria. It was decided that the screening criteria will be revisited once in 3 to 5 years. So which infants need to be screened? Do we need to screen, a 35-weeker, or we can do a 32? So the guideline says any baby born or at or before 34 weeks, birth weight less than or equal to 2,000 grams. And if the babies are born even after 34 weeks, but they have associated risk factors. And finally, then there is also issue of, we have to give consideration if the pediatrician, based on his discretion, if he feels that there might be a risk, you might need to do ROP screening. See, these are the 4 different criteria to do the screening. So what are the risk factors? Basically, the child has requires cardiorespiratory support or respiratory issues, or hemorrhage, or requiring a blood transfusion, or has got a systemic infection, and the poor postnatal weight gain. This is also an important risk factor for considering ROP screening. So when to perform the screening? Ideally before discharge from the NICU, and there's something called D30 or day 30 strategy. Ideally better to do the first screening before 30 days of life. And if the baby is born even at 28 weeks or less, lower birth weight, extreme lower birth weight, maybe it's better to do even at 2 or 3 weeks of postnatal life. And where to do the ROP screening? As I told before, better to be done in the NICU before discharge. But if the baby is discharged, if the baby is stable, sometimes they discharge earlier. You can follow up the baby in the clinic when you go for the NICU visit, or the baby can be brought to a clinic. So the normal procedure, obviously, we ask the mothers to avoid feeding because you don't want aspiration during ROP screening, and dilate the pupil with diluted tropicamide and phenylephrine. And better not to repeat the drops. Sometimes the drops keep putting, the nurses keep putting the drops since it's not dilating. You have to educate the nurses maybe 2 or 3 times, but not more than that, because the multiple installation of drops, there is always a risk of systemic side effects. And sometimes if the pupil is not dilating, then it could be because of advanced ROP. And during the examination, better to keep the infant nicely tucked with a towel, I mean, whatever the wrapping they have. And it's usually done under topical anesthesia. And if you have a trained ophthalmologist, the ideal way is going to be an indirect ophthalmoscopy. But places where there's not much of availability of the trained ophthalmologist, then tele ROP screening using a wide field camera like RedCam can also be done. And the importance of documentation, especially with recent medical legal issues coming up, it's very important that one documents both the findings and the management decision, whether we want to observe or you want to consider treatment. And the second important point to be noted or recorded is also the date for the next screening. It has to be recorded in the medical records, and also informed. The parents have to be informed. This is mainly important. This is mostly important when you see the baby in the NICU, and sometimes in the discharge summary, the nurses in the neonatal unit may not. Sometimes they forget to mention in the discharge summary, and when they call them or the babies come late, if you ask them, they say that we are not informed. So from the medical legal point of view, also it's better to inform or document the next visit date in the records. And how frequently to follow based on the stage. Obviously, if it's a sight-threatening ROP, requires immediate treatment. But if there's no ROP or non-sight-threatening ROP, then based on the stage of ROP, you need to follow. Basically, average around 2 weeks. If it's zone 1, go for 1 week. But if it's only stage 1 or 2, as a regressing ROP in zone 3, then you can even wait 2 to 3 weeks. The next question is when to stop the ROP screening. No further screening is required if you feel that the retinal vessels are mature and the retinal vascularization is complete in both eyes, and the ROP, if it's been before, and whether it's regressed spontaneously. So just to share my experience in Erode, so it started in 2007. So I came back from UK in 2006, was contemplating about ROP screening. And fortunately or unfortunately, my son went through and had a rough postnatal course, and he was in ventilator for 2 weeks, was a 35-weeker. So he did undergo ROP screening. After that, that was one of the motivation that I thought I should do start early. So I visited all the neonatal units, created awareness about ROP screening. And I was lucky to have motivated young neonatologists who was just starting their neonatal units. And they're very receptive, and also the important thing is not only the neonatologists, it's important to educate the nurses, because they are the ones who are going to be the babies. And I keep telling them that as we discussed before, as Dr. Srinivas also was talking about, I tell them oxygen is good for life, not for the eye. So they keep thinking that we have to maintain saturation at about 95%. And I had the unique opportunity to work with Dr. Fleck in Edinburgh, Royal College. He was a pediatric ophthalmologist. He has published a good paper where he has clearly documented that frequent fluctuation in saturation of oxygen is also a big risk factor for ROP. And I printed out all the screening criteria and displayed on all the NICU, because sometimes they forget. So just as a reminder, it's put in a place where they can see, so that we don't miss any baby who fall in that screening category. And this is our ROP clinic, and normally I see on alternate days. On 30 days I don't see, but I ask the babies to come early in the morning, so that by 10:30 they're out, so that they don't need to wait on the main OP. And this is the normal numbers. Normally I do. Last year we screened about 1,122, did 1,122 screenings at our ROP clinic, and around 400 in the actual NICU in various hospitals. And we do have a good optometry backup. And recently, one of the MOptom students is doing a project on refractive error in newborns and especially preterm babies. So he's just doing retinoscopy, and these are all preterm babies who had come for RP screening now come for their regular follow-up in the pediatric OP. So my experience with, the disease as such, as Parag pointed, this was in 2009-10, where suddenly there was increase in incidence of AP-ROP. Had a word with Parag. These pictures are courtesy from Aravind Eye Hospital, and thanks to Dr. Parag for sharing the pictures. And in fact, Dr. Parag, these cases were referred to him, and he made a nice Excel PowerPoint. I don't know whether he remembered. This was way back in 2010. Around 6 babies in just a matter of 4 months. Even you can see in this, I know this the picture, the fonts are small. Even a 33-weeker had aggressive posterior ROP. So all these patients underwent treatment, and of the 6, I think one child, one eye, we lost vision with their stage 5 ROP. And there's an excellent paper by Parag, aggressive posterior ROP in large-term preterm babies in South India. He shared the article with me, and also told me to educate the neonatologists about the importance of using blenders. So after that, there was a dramatic decrease in the incidence of AP-ROP. Rarely, I'm not seeing one in the last 2 years here. But yes, it's made a big difference. So as discussed before, the educating the neonatologists and the nurse is the most important thing, because the primary prevention is always better. And sometimes when I do the ROP screening, there are scenarios where I'm not sure that should I observe, or should I refer, or should I treat. And there are a few scenarios where we had a child with it looks like plus disease, but there's no evidence of ROP. And I had a chat with Parag, and we have a unique collaboration where an Erode I do most of the screenings in the private setup, and in the government setup, Aravind tele screening is done. So they come here on Friday. So I spoke to Parag. I said, okay, because the baby could not be shifted. So he said, why don't we do the screening? And the screening was done, and it was not no other evidence of ROP. We just observed it. And I had another child with unilateral ROP. I was wondering how unilateral side-threatening ROP can happen, and Parag did confirm, and laser was done. And the third scenario, I think Sriram has raised. I have quite a few babies in this scenario, 54 weeks, stage 2, zone 2 to zone 3 ROP, not regressing. Should I laser or just observe? So in addition to, in these scenarios, as I said before, where if in a dilemma, they have the advantage of having a tele screening, and if required, refer the patient to Coimbatore. And when you start doing ROP screening, besides ROP, you do come across academically other diseases, morning glory syndrome, just a few of them I listed. And there's one interesting case of acute retinal necrosis. This child was referred for ROP screening, and suddenly when I looked at the picture, it's completely different. And I think Parag managed, we gave him IV acyclovir, and the child did really well actually. Child was lucky that it was born preterm, because if born term baby, would not have done the ROP screening at all. And final one interesting case, this is to emphasize the importance of dilated fundus examination, not only for anybody who's doing ROP, even for an ophthalmologist who doesn't do ROP. This is a preterm child, post-gestational age of 42 weeks, and referred by the pediatrician for complaint of watering. So the child did have a congenital NLDO. So I explained to the mother that yes, NLDO, you need to do massage, but also told, since it's a preterm, better to do a dilated fundus exam. The child was born in Kerala. The mother said they're already done ROP screening in Kerala, and the child, she was told that everything is fine. So she was not keen to have the dilated fundus examination. So I re-explained, so she agreed reluctantly for fundus examination. So when I looked at the fundus, I had the shock of my life. She had stage 5 ROP. So, the child was referred Coimbatore, Parag, Dr. Parag saw the patient and then went to SN, I think, I don't know, PB sir remembers, PB sir saw the patient, and the patient is actually in Singapore, from Singapore. And they went to Singapore, I think, got operated from with Dr. LG. So I used to wonder if I had not seen dilated the fundus, definitely I would have been pointed why this was missed. So the take-home message is any preterm child, even if it comes after 2 months, 3 months, better to do a dilated fundus examination unless you have documented evidence that ROP screening was done and the retinal vascularization is complete. And about imaging, yes, imaging is useful for two things. One, documentation, and second, where we are not enough trained ophthalmologists are there, then definitely is useful for tele-ROP screening, which Arvind is doing in a big way. And for this, I request Dr. Parag to share his experience about use of RedCam and other cameras and how it is done. And I'd also like to, before I finish, acknowledge all the neonatologists and especially the NICU staff in Europe, and also Dr. Parag for helping me in this journey. Thank you.
Thanks, Bala. Sriram, you want me to show the video or are we already overshooting?
Yeah,
the time?
I think you can show the video now, Parag.
Okay. Bala, can you stop sharing?
Or maybe you can do it at the end of your presentation.
My presentation is over. Yeah.
Oh, sorry, I forgot that. Yeah, so you can show the video now. I think this is most relevant now.
Okay, fine. It's just a short video.
Yeah, I just wanted to add something to what Bala said. I think Bala was very right in pointing out that any preterm baby, you should take it a point to see the fundus. Probably I would say, go out on a limb and say not only preterm baby, any patient. Either you see the fundus or you at least put it down on record that you wanted to see the fundus and it's a patient who refused for a dilated exam. That is what will save you in a court of law.
Yeah, extremely important, Sriram. Very, very rightly mentioned. I think complete examination is very, very important, irrespective of whether it's premature or not. Because what he has rightly made, he have pick up few other cases, also other fundus pathologies and developmental anomalies. You can pick up those things as well.
So this is a short video of the RedCam and telescreening. So this just shows that because it's a little bulky and a costly equipment, and the roads are in India not so good, so we have to take care. So we had made a sort of a vault inside the van with shock absorbers, so it can really sustain the long journeys. I always compare ROP screening to a train or a flight compared to cataract. Cataract screening is like a ship. Ship will sail once in a month or once in 3 months. You can do the screening, but once you start ROP screening, it has to start every day. I mean, in every week for the NICU. And if you're doing multiple centers, then every day the train has to leave and go to the NICU to do the telescreening. And so it's a really good, it's a costly thing, but it's really good because it really reaches the people who really require this treatment and screening. Because now we are seeing that things are shifting to these smaller NICUs, the government, the SNCUs, which are starting by all the district hospitals. And all of them, there are the babies who are like 28 weekers who are surviving. And unfortunately, no one is doing ROP screening there. So the whole idea of starting this program is to go and screen when no one is screening. And we usually target the government SNCUs. And this is the RedCam shuttle being used by the technicians. And it's really nice and very easy way to teach them. And they can store the images. And after the images are stored, we just transfer them to another laptop from where it is uploaded on a server. And at the base hospital, the images come. We report the stage and send back the reports. It goes immediately, and the counseling is done on the spot. So it really saves so much of time and energy of these sick babies who can't travel so far. And it really has become a big impact for, for everyone, especially the government SNCUs. And of course, the RedCam, like I said, it's costly. It comes to almost like $1 lakh. And now we have the Forest Neo, which is also, which is not as costly. It is cheaper, and we can get to around 20 lakhs also, but it still is costly. So in this grant, we had a USAID in the SEVA grant. We also tried the peak vision camera, which comes like a small pen. Unfortunately, it did not do that well. And we tried this smartphone based MI RedCam, and that also is okay, but then it's not as good as the digital imaging done by Forest Neo RedCam, because it's a white field here, it's not the white field. And we have tried the artificial intelligence also in this, and it's a work in progress. And hopefully this will change, and the cameras, new cameras are coming, it will be cheaper. And this really has made an impact in the sense, like when we started, it was just in Coimbatore city, and then we expand telescreening. And the same way in all the Arvinds started. Now all the Arvinds are doing telescreening, and in a week we screen more than 200 babies across all our system, and more than 10,000 babies per year. And this part is, nobody would have screened them. So that is the power of telescreening, and it's a really good thing. And we just hope that the cheaper cameras come, and many people can utilize this technology. So that's all.
Congratulations.
That's an
Prakash.
excellent
Nice
video,
work.
sir.
Thank you. So,
That's an excellent video, sir. Thank you.
okay.
I'm
Thank you.
glad.
Okay.
I'm glad to introduce Dr. Janni Srinivasan. She's my friend from RIO, my batchmate. She did her MBBS from Coimbatore Medical College and her MS from GOH. And then she did her VR fellowship from Shankar Nethralaya. And right now she's working as an associate consultant in Department of VR, Shankar Nethralaya.
You are
Janani,
muted,
I think,
Dr. Janani.
yeah, muted.
We can't still hear you, Dr. Janani.
Not audible.
Please unmute your.
You are still showing as a muted. You can see the cross on your mic actually.
Some technical issue, I think. She wants to go out and rejoin.
Then can we proceed with the next talk? You can
Yeah.
talk.
No, Parag, it will take at least few
Yeah.
minutes. We can go to the next talk. No
Yeah,
issue.
Saib, can you just introduce the next speaker?
Yeah.
Renu.
Then I will call Dr. Renu. Renu, are you ready?
Yes, sir.
Yeah.
Am I audible, sir?
Yeah.
Yeah. Dr. Renu, he did his PG from AIMS, and right now he is working in Arvind Nagar. He is actively involved in ROP and ocular tumors and all. So over to Renu for his talk on anti-VEGF for ROP.
Thank you, sir. I'd like to thank PNI RK sir for arranging this wonderful CME, and especially Pramod sir and all our moderators and for this arranging this. Are my slide visible?
Yes.
Absolutely. Yeah. Carry on.
Yeah, Renu, put the full slide. Yeah,
Yeah. Sorry for the delay.
right. Go ahead, Renu.
Yes, sir. Yes, sir. So, my talk is on intravitreal injections in the context of retinopathy of prematurity. As we all know, it's about the burden of the disease. As per WHO data, there is 135 million diapers worldwide as of 2010, and 11% of those babies were born preterm. And India is the leading total number of preterm babies born every year, with 18,000 infants going blind every year. The incidence of ROP varies from 20 to 54%. Right now, the gold standard of treatment for ROP babies is believed to be lasers. But even the gold standard still has its limitations, like in severe cases like ARP and in zone 1 diseases, the failure rates are still on the higher side, and so the unfavorable structural outcomes, even with laser in the major studies, are still 10% or so. And similarly, when the media is hazy, the pupil is not dilating, and the baby is not stable for a 1-hour procedure. Again, all those are places where we wish we had a different treatment. And similarly, the technical expertise is the equipment and time needed are again other limitations. And the long-term side effects like field loss and myopia are more common with lasers. In this context, really, the advent of anti-VEGFs has made a major. So we have many anti-VEGFs commonly which are used. Some of which the most commonly used ones are bevacizumab, ranibizumab, and now we have biosimilars of ranibizumab, aflibercept, and in some rare reports of conbercept and pegaptamine, which we don't use commonly. So coming to bevacizumab, it's a full-length humanized murine IgG monoclonal antibody with a higher molecular weight. It binds to all VEGF isoforms, and it has a long half-life in the vitreous in the adults. Also, it goes into the serum and has a serum peak level at 2 weeks post-injection. And the serum half-life is found to be around 21 days in preterm infants. And the decrease, and this can suppress the VEGF for as long as 8 weeks and above. So, even though it is the most frequently used and studied in the intravitreal anti-VEGF for ROP due to widespread availability, low cost, and effectivity, more than 200 articles on the same. Again, the dose is not similar to adults. We use starting from half dose of, we use adult dose is 1.25 mg. We use half of that, 0.625 and below. There are doses up to 0.03 which have proven to decrease the ROP. And the landmark study which brought the bevacizumab into perspective was a beta ROP study, where they found that the recurrence of ROP was only in 4% of eyes in the bevacizumab group compared to 22% in the laser therapy group. So they mainly studied the zone 1 disease and zone 2 posterior. So the study came in New England Journal of Medicine and changed the role of anti-VEGF in ROP. But more importantly, they found that the huge benefit of the injections were found mainly for the zone 1 disease, but not that significant compared to laser when it came to zone 2 disease. So, and one major thing which is where the treatment makes it different from lasers is the development of peripheral retinal vessels. It continues after the treatment with an intravitreal anti-VEGF agent. but conventional laser therapy lead to permanent destruction. These images are from the beta ROP study published images, where you can see that first the top two images of the laser showing the permanent destruction of field in the periphery, whereas a more severe case, which is shown below, showed progress of normal vascularization to the periphery. So these are examples from our own injection babies, where within 1 to 2 weeks post-injection, the entire ridge has disappeared, or even the vascularization has come back to normal, the plus has disappeared. Coming to the next anti-VEGF, which is commonly used, is ranibizumab. It is a humanized monoclonal antibody fragment, which is smaller than that of Avastin. It has affinity for all the isoforms of VEGF and 5 to 24 greater potency. Its serum advantages are it has a shorter serum half-life, only 2 hours in adults. And the systemic effect on VEGF has been proven again to be less prolonged, only for 7 days. So in the landmark trial, which Arvind also was a part of, the Rainbow trial, compare the efficacy and safety of ranibizumab in 0.2 dose and 0.1 mg dose compared to laser in 225 patients with ROP. They found a clinically relevant difference in treatment success between the ranibizumab arms compared to the laser treated arms at 80%, 73%, and 66%. So following this study, Novartis got approval for using this use in ROP. So ranibizumab, the advantage it has lower potential toxicity than bevacizumab in infants with ROP. In the Rainbow study, the T-half of ranibizumab was about 5.6 days and 0.3 days in systemic circulation, compared to bevacizumab with a longer serum half-life of 21 days. So now we have so many biosimilars in the market, and it is good that India is one of the first countries to come out with data on biosimilars in ROP. This study came in IJO this year only. 118 eyes of 59 in infants injected with Razimab. It has proven to be safe and effective in treating ROP. About you can see in the tabular column the number of eyes with complete resolution was around 19%. Around 1/3 of the eyes had a recurrence, which is known fact with the ranibizumab molecule. And around near 46% had incomplete vascularization, in for which they did lasers around 39 days after the injection. So the other molecule, which is again now approved for ROP, is aflibercept, based on Firefly and Butterfly studies, with the treatment success rate of 85% versus laser 82% in their study, and requiring lesser rescue treatments of 4.8%. But the recurrence rate was again 21% in with aflibercept, and the ocular SAEs and systemic SAEs were 13% and 24% in the study. So injection versus laser, there are some intra-op and post-op considerations, like small pupil media haze and unstable babies, which we already discussed. Their injections have more of a role. And similarly, but you have to keep in mind the post-op consideration, since it's an invasive procedure, endophthalmitis, cataract, myopia, and long-term compare it with the reduced long-term complication of myopia and field loss. So current indications in most of the practices is for the posterior and more severe disease like ARP, the half-zone ROPs, the zone 1 ROPs, as well as when plus is there and you're planning for an ROP surgery for stage 4 or 5 as an adjuvant to the ROP surgery. And some cases where because of media haze or pupil problems, you have to go for the injection, or when the laser has failed. So definitely contraindications are the infective foci in the eyelids and conjunctiva. It is risky to do an invasive procedure. And similarly, if it is on the later cicatricial stages, it can induce a possible crunch and RD in these cases. So this is a video of the technique of the procedure. So you can do this procedure either with an indirect ophthalmoscope or with an operating microscope, depending on convenience and expertise. So many of though usually for intraocular injections, usually we say only to do one eye at a time is better. Most of the time the disease is severe, and we are most of the practice is to go for bilateral simultaneous injections. So here we are injecting at 1 mm or less from the limbus, and care has to be taken to be vertical in position so as not to hit the posterior surface of the lens and cause a cataract. And similarly, there are published protocols of shorter needle with 4 mm needle length, whereas we use around 12 mm needle length 30 gauge needle. So the use of antiseptic antibiotic pre or post-op is again important, and follow up in the next 2 to 3 days for looking for endophthalmitis early signs is again important. And similarly, these patients can have a recurrence depending on the type of injection at any time between 3 to 4 weeks to anywhere to 4 months and above also. So we have to recheck these babies every 1 to 2 weeks until you give a laser or until the vascularization is mature. So again, another thing, when you are doing the bilateral injections, you have to use a separate set of instruments for both the eyes. You have to change the gloves in between. The entire set has to be changed. And wherever possible, give injection from 2 different batches of injection where possible. So again, coming to the complications, the common local complications which are possible are, it's actually not common, but intraocular inflammation, endophthalmitis, ocular hemorrhage, corneal opacification, cataract formation, and retinal detachment are all complications which are having a lower incidence. And long-term ocular complications can include abnormal vascular developments, shunt vessels, and some instances of refractive errors such as high myopia and astigmatism. And systemic effects of intravitreal injections are again, the concern is because of the entry into the serum and the longer serum half-life in some drugs like bevacizumab. So coming to the more commonly told systemic complications are possibilities of developing neurodevelopmental delay, lower motor skills, and rare complications like hepatic dysfunction, nephropathy, thromboembolic events. But there is one thing that should be kept in mind is that all preterm babies and ROP babies are already at risk of a neurodevelopmental delay. This is a study which was done many years back in collaboration with Arvind Hospital. And premature infants with the diagnosis of ROP were found to be at a higher risk for developing neurodevelopmental delay, even when the visual outcomes are normal. So the association of neurodevelopmental delays in ROP may have a common ecological basis, such as damage to the vascular and neuronal pathways during maturation. So when we give a drug which also can have an effect on this, added there's always confusion as to whether it is increasing the neurodevelopmental delay or not. Even in spite of literature search, we still not come to a conclusive evidence of whether it increases or not associated with an increased neurodevelopmental issues. So these are some studies which I could find in the literature. Some which are saying that it is associated with increase, and some which say that it does not have an association. Again, another thing to be noted, which was again which had come up in the discussion, was about the recurrence of ROP, because we are altering the course of ROP, and recurrence can come as late as a year and or above also, as some case reports have shown. So in Rainbow Trail, 31% of the ranibizumab infants had recurrent ROP requiring retreatment in the 6 months after the initial injection. Whereas in our other bevacizumab studies are up to 23% retreatment rate. In addition, a study of 241 infants treated with bevacizumab found late reactivation of proliferative disease in 8% of children. And retreatments are to be performed as long as age 65 age-adjusted weeks after the initial treatment. So coming to our experience post Avastin, we usually do delayed laser at around 2 to 3 months post injections. This was what we had published in 2018 pertaining to data before the 2016 and 17. So around 14 babies, 28 eyes diagnosed as having APROP, and 15 eyes diagnosed with type 1 ROP. Mean birth weight was 1,340 and age was around 30 weeks. Mean PMA at which the injection was given was around 35 weeks, and the mean PMA at which the laser was done was 44 weeks, with an interval of between the laser and injection of around 9 weeks. So recurrence of ROP post IVB before the photocoagulation was noted in 2 patients, or 4, that is around 6.8% of the eyes had a recurrence during our follow-up period. The rest of them had a routine injection because of lack of vascularization in the periphery. So The take-home message is anti-VEGFs are wonderful drugs. They have rapid action and very highly effective in treating an ROP as such. But you have to keep in mind the risk of ocular and systemic possible adverse effects. Also, keep in mind the late recurrences and altered disease course. The dosage, timing, and case selection are very important while you are treating these preterm babies. And most importantly, you have to discuss your planned procedure with the parents and take an informed consent before giving an intravenous injection for ROP. Thank you.
Thank you, Renu. That was a wonderful talk. And do you take like a fitness from the pediatrician for injections, for intravenous injections?
Yes, sir, definitely, definitely.
What are the things to be like blood investigation you do advise?
Usually we check the blood sugars, the blood urea creatinine, and platelets. And these are the basic investigations that we do. In addition, if the pediatrician suggests some other investigation, we also add that.
Dr. Renu, I have a doubt.
Yeah.
So it's a very basic question. Considering the dead space in the needle, how do you make sure the adequate volume of the drug goes inside the eye?
Usually here we use pre-filled syringes, and when we push out we have more than 0.04 ml of drug in our syringe. We inject out the air, and at 0.02 mark, though we say it as 0.625, we usually give 0.5 mg, that is around 0.02 ml, the first mark in the needle. So, and we keep it at that level, and then we inject, it pushes out that 0.02 ml. So the remaining drug in which is there in the hub of the needle actually does not matter.
Okay. So you
Actually,
keep it at 0.02.
Yeah, because actually once you expel the air and you have a just drug coming out of the tip of the needle and whatever extra you have, but so, and once you have a marking on the syringe, because what you push is exactly that is going to, so the space which is there in the needle, which is approximately 0.06. So that remains as it is, because you push from the needle out, and what is done in a syringe, it get pushed in the syringe hub. So that matches. The practical difficulty is nice to say, like even 0.03 also work, 0.2, 0.05 also work. But when you inject, we have to ensure that adequate drug goes in. And that's why on an average, all of us agree that half dose, because if you, yes, effectively even 1/4, 1/10 also works, but how to inject that 1/10, that's a practical difficulty. And quite sometimes if you try to do that, you may land up injecting not at all, when no drug will go inside the eye. So that's the practical difficulty.
Do you vary the dose depending upon the severity, sir?
Sorry?
Do you vary the dose depending upon the severity?
Not really, because it's really not necessary to vary the dose accordingly. I mean, according to severity.
Treatment failures are very rare in giving antivirals.
Which one?
So,
sorry.
Normally at the normal half dose that we give, usually we have not seen much of treatment failures.
Agree. Yeah, but overall, see, like long-term recurrence is much more with anti-VEGF against laser. That's a ground reality.
Definitely. Yeah, yes, sir.
I think then we will move on to our speaker, Janani.
Yes, sir. Am I audible now, sir?
You're audible,
Yes.
your slides, sir.
I think that was a good note to start the presentation. The long-term recurrences are much less in laser. So here, my slides are moving, sir. I'm here to talk regarding lasers and retinopathy. Sorry for the technical glitches.
Yes,
So the synopsis of the talk include introduction, indications, technical aspects, follow-up, advantages and disadvantages of laser, and conclusion. So moving on to introduction. So laser involves ablation of the peripheral avascular retina to reduce the VEGF flow to arrest the progression of the retinopathy of prematurity disease. And it is one of the most rewarding treatment options overall for prevention of late stages of disease, which is much sight-threatening. It is definitive treatment, portable, can be done in NICU, and the regression pattern, most importantly, mimics spontaneous regression. And it can be used as a prophylaxis in the sense to prevent, like I told you, vision threatening ROP, as well as the treatment either intra or in some stages of late stage of the disease. So coming to the milestones, the most important information we got regarding peripheral ablation is from the cryo ROP, where the threshold disease was defined and cryoablation was suggested. And then with the ETROP, that is the early treatment retinopathy of prematurity study, wherein from the cryo ROP cohort, they took patients who met the risk criteria, that is 50% of increased risk of unwanted complications, and those patients were offered randomized one eye to early ablative treatment and the other eye managed conventionally. That is, they were treated when they reached the threshold disease. And they found that there is significant reduction in unfavorable visual outcomes and structural outcomes at 9 months of age. Both the results were statistically significant, and hence the study supported ablative therapy for type 1 pre-threshold ROP and wait and watch for type 2 pre-threshold ROP. So now when we look at the indications, most important indication is aggressive retinopathy of prematurity. Here it's used as a combination therapy along with anti-VEGF injection. Anti-VEGF injection helps in attaining a rapid reduction in VEGF load, simultaneously allowing the posterior pole to vascularize, whereas given the extensive load of avascular retina in zone 1 disease, laser helps to reduce the peripheral avascular retina, and anti-VEGF helps in allowing maturation of the posterior pole along with reduction of VEGF load. Of course, threshold disease, like already defined in the cryo ROP study, and type 1 pre-threshold ROP, which includes zone 1 any stage of ROP with plus, zone 1 stage 3 without plus, and zone 2 stages 2 or 3 which plus. Extended indications include even pre-threshold low risk with very doubtful follow-up or poor systemic profile, or even in stage 4A, if the retinal detachment is less than 6 hours. Quite a some we see that the traction and the vascularity definitely decrease with laser even in these cases. Most importantly, as a rescue treatment post-injection, especially once the posterior pole is well vascularized, and of course during vitrectomy. Most important key to success from laser treatment is early initiation within 24 to 48 hours, preferably the same day. So this is an example of indication like zone 2 stage 3, where we are with the pre-plus, we have started the laser treatment. And technical aspects, the most important crux of this topic. So the prerequisites or informed consent from the parents. The setup can be in an NICU, semi-OT, or even OPD, but the most important thing is monitoring of vitals with the help or under the supervision of an anesthetist or pediatrician, along with a suction apparatus, resuscitation, and intubation equipment next to the mission. And the equipment we use is, of course, laser and direct ophthalmoscopy using a 28 or at plus 20 conducting lens, and scleral depressor and alfonso speculum, preferably autoclave. Of course, ROP drops, which are constituent 0.75% tropicamide and 22.5% phenylephrine, instilled twice, 10 minutes apart, at least 30 minutes. And already the previous speaker has mentioned avoid repeated use of dilatation drops, the fact that systemic absorption is very high. The child must be fed and burped 30 to 60 minutes before treatment if topical anesthesia is used, or 4 hours if general anesthesia is preferred. So most of Indian setup, we use topical anesthesia, except if the baby is very large, baby will not cooperate more than 3.5 kg, 4 kg. We tried topical laser, not happening, then probably we have to think of general anesthesia. And the baby should be covered properly to prevent hypothermia, and it should be done in a temperature controlled, clean environment. So the laser equipment can be green laser or a diode laser. Theoretical advantage of diode laser is deeper penetration, less risk of cataracts. And with the green laser, the localized cataracts can happen due to the absorption by the tunicosa vasculosa and lentis. The alfonso speculum typically having an option for finger grips for inserting the speculum, and an interlacing blade. It helps facilitates the insertion of speculum in eyes with narrow palpebral pressure, 28D or 20D condensing lens, and the wire vectis. We have to make sure the edges of the wire vectis is smooth, curved, and rounded rather than thin and sharp, because the thin vectis can bend or it can even cut through the sclera. So preparation of the baby, as I mentioned, the chest leads are put, the pulse oximeter is connected, and the baby is nicely wrapped in a heat controlled environment. The warmer is there, and now the baby is ready for the laser. So settings, the target area is entire avascular retina, anterior to the ridge up to the ora. Initial power depending on pigmentation, 150, 200. The target is a desired burn, the yellowish burn, and the power has to be titrated for, say, anterior retina, less power is needed, whereas posterior retina, we need more power. And exposure is 100 to 300 milliseconds. Near confluent burn is needed. And number of burns depending upon single sitting or multiple sittings. Generally, if it is a single sitting, 3,000 to 4,000 burns per eye in zone 1, or 1,000 to 2,000 in zone 2 or 3. And this settings depend upon general condition of the child and the surgeon comfort and how the child behaves during laser. All these parameters determine the number of sittings. And most important thing is complete 360-degree viewing of the retina at the end of the procedure to avoid skip areas. So this is an example to show a near confluent laser burn. And what are the do's? So important to mark the posterior border in cases of zone 1 because there is ill-defined foveal anatomy, abnormal vessels, vascular shunts in these cases, especially AROP. And generally we move from easier area to difficult area. First we start with the posterior retina close to the ridge, move on to mid-periphery, then anterior retina, then move to the next clockward. And at the end, we see the entire 360 degree, like I already mentioned. And especially, we need to cover the islands of avascular retina and otherwise vascularized posterior pole, as well as the posterior slope of the depression, where the laser reaching may not be like how we see the anterior part of the depressed area. So those areas we have to look for skip areas specifically. And while treating the posterior retina, the depressor is held against the forenasal conjunctiva rather than actually depressing it. It's just used to stabilize the globe. And for the anterior retina, the depressor is actually used to depress the globe against the bulbar conjunctiva close to limbus so that anterior retina is visible. This point I'm mentioning to avoid continuous scleral depression. Many a times we just have to rotate and stabilize the globe. We need not always depress to do the laser, thus avoiding continuous scleral depression. And viewing angle needs to be more vertical and make sure we always the view angle central rather than too much tilted. And monitor vitals throughout the procedure. Pay attention to the baby. If needed, can allow feeding in between the sessions. So the eyes has to focus on the laser and the ears has to focus on the monitor. And there is need for frequent irrigation of the cornea. And one should be alert. A very quiet child must arise suspicion of an apnea or a cardiac arrest. We should pay attention to the sounds of the baby, whether he's making clear vocal sounds without any secretions in the throat. So what are the don'ts? Like I already mentioned, avoid too much scleral depression, especially depression and sudden release. This can cause pupillary constriction as well as intraocular hemorrhage. And we have to avoid rotating the globe to the extreme ends, avoid burns anterior to the ora, and avoid heavy confluent spots in general, more so on the horizontal raphe. So this is an example to show that all the quadrants of the retina must be checked and make sure there are adequate near confluence laser burns. What are the challenging scenarios? For the fact that ROP laser itself is challenging because of the constant movement of the child, the constant crying. For a beginner, it can be really challenging. It needs learning curve. Apart from that, the small size of the eye, steepness of the cornea causes more peripheral abrasions. It's difficult to get a focused burn in the periphery. But once after a learning curve, people get to get used to the laser. And even then, there can be some challenging scenarios. One is the aggressive posterior or aggressive ROP, where the posterior zone is very difficult to, the posterior part of the laser will be very difficult to determine where to stop, like posterior, because of immature foveal landmarks, hazy media, and even hemorrhage is situated posteriorly. Less dilating pupil, we can try to put some spots, or even we can give anti-VEGF and then do the laser. Sometimes simultaneous firm pressure can itself dilate the pupil. Purely non-dilating pupil, media haze laser cannot be done, then we have to go for other options like anti-VEGF or very rarely cryotherapy. Sick child still can consider anti-VEGF under systemic stabilization or can plan laser in multiple sessions. In stage 4A, RD less than 6 clock hours, still laser is an option. Bradycardia, multiple episodes of apnea during the laser, just stop for some time, remove the speculum, wait, again resume. If it's not happening, it can be planned in multiple sittings. And when to do the laser post anti-VEGF as a rescue, very variable. However, any sign of disease progression or relapse, one must also need to consider FFA if at all we are not able to see obvious avascular retina. So hazy view during the laser and the corneal haze, it can be caused by excessive depression of the globe, prolonged duration, solution is frequent irrigation. And hyphema, the source is dilated iris vessels due to laser burns over the iris vessels, fluctuations in IOP. We have to wait for some time, again plan laser or plan next day. Vitreous hemorrhage, it can indicate severe disease progression. Some peripheral view is there, we can try lasering, otherwise we have to look for other options like surgery. So here we can see the APROP where the posterior, there are so many vascular shunts. We are not sure how posterior we can go. And on the right side, there is an example of a vitreous hemorrhage. Some peripheral burns are seen, shown by the black arrow, faint burns. So we have tried to do some peripheral laser here. So pain management, there is a scoring by the premature infant pain profile revisited score, which is based on heart rate and oxygen saturation as well as the facial movements of the child. So this helps to see how painful is the procedure, and there are multiple studies based on this. Although general anesthesia is the standard of care in Western countries, still in India, topical anesthesia is the most common method and it works. Given the systemic complications already these children having, and general anesthesia can be very risky. And some non-pharmacological methods, the sucrose or dextrose water, which releases endogenous opioids. But only thing is it's very short acting. Definitely this sucrose dip wick helps. And it is important to see that the wick is quite long. It doesn't go and catch in the child's mouth. And the pseudo-analgesia, which is short acting, this no pain ROP trial, fentanyl and ketamine, these studies are not very popular. The analgesia is very short acting. In the aerosol containment box, which we found out during the COVID era, it helps to definitely minimize the aerosol generated during the ROP procedure. And it has multiple apertures for the assistant, for the ophthalmologist, as well as for the suction apparatus to remove most of the aerosol. And next is the follow-up. For zone 1, it should be within 3 to 4 days, and for zone 2 or 3, it can be within a week. The follow-up order, which is the natural, follows the natural regression of the disease. First will be the reversal of stress, followed by changing of disease, and then normal vascularization. So, if we see this picture, definitely the NVEs have regressed, as well as the dilatation and tortuosity of the posterior pole vessels have reduced. And now moving on to additional treatment. So when do we do the additional laser? When there is lack of expected regression of vascular signs, or when there is worsening, we have to look for skip areas, especially when there is tortuosity only in 1 or 2 quadrants. We can trace that periphery and look for skip areas in that periphery, and it's important to treat them. And even if some cases we need FFA to look for the skip areas, sometimes it can also be combined with an anti-VEGF. Whenever we see increased traction, so when we follow these 2 things, 1, there is regression or increased vascular signs, and 2, when there is any traction. So when it is mild, non-progressive, we can still observe. But if it is significant with documented progression, we have to go for surgery. So coming to skip areas, when there is active disease, like in this left side image, we see some retinal hemorrhages, some tortuosity is there, old laser marks are also there, but here we need to fill in because there is still disease active. Whereas the image on the right, almost regressed NVE, there is some skip areas, not much vascular signs. We did follow this patient for quite a long time, and the NVE also regressed. Here we just observed without any additional laser. So here, every case-to-case scenario, we have to take a call. So now traction, these 2 cases are examples of non-progressive traction. One is at the periphery, one at the posterior pole. Both the cases we observe. And advantages like over cryotherapy, of course, most important, can be done under topical anesthesia, less post-operative inflammation, posterior lesions can be easily treated. Still, cryotherapy can have a role in non-dilating pupil, hazy view, and ablation and detached retina. Of course, laser versus anti-VEGF, laser is more a definitive treatment, less chances of relapse and recurrences, no risk of infection, no risk of systemic VEGF reduction. Most of these have been told by the previous speaker. But however, laser needs a more equipment is needed, trained ophthalmologist, and it can be difficult in pure pupillary dilatation, especially AROP, hazy media, and sick child. So the complications, anterior segment corneal burns, especially if it is dry, iris burns, anterior segment hemorrhage, inflammation, and posterior segment under treatment or over treatment, functional myopia, peripheral field constriction. So to conclude, the key to success is early initiation, the complete treatment, ablation of the entire avascular retina, and complete examination at the end of the procedure. And during the entire procedure, vitals have to be monitored and proper follow-up, watching for signs of regression and progression of traction. So these are my references and my acknowledgement. So laser is the gold standard treatment for retinopathy of prematurity up to stage 3. On that note, I conclude my talk.
Thank you. Thank you very much. So in interest of time, I think we'll go to the next talk. Next speaker is Dr. Pramod Bende, who is a well-known person in retina and ROP circles nationally and internationally. And he's the director and the chief of retina services of Shankarnetralaya Chennai, having a lot of experience in treating ROP and especially the surgical aspect. So we're lucky to have him here, and thank you, sir. And kindly proceed with your talk.
Yeah, thank you. Thank you very much, Parag and TNOA, and Dr. Ramakrishnan, and particularly Sriram giving me this opportunity. We'll quickly jump to the stage for surgical aspect. Okay, so despite adequate laser and obviously anti-VEGF, we have still few cases progress to retinal detachment, and more neovascularization as far as clock hours are concerned, you are higher risk of macular detachment, and that's what your surgery part comes into play. So indication for surgery would be stage 4A, B, and stage 5. An option what we have is scleral buckling, lens sparing vitrectomy, combine lensectomy and vitrectomy, and sometimes you can add scleral buckling as well. All three procedures can be combined in a select group of eyes. So coming to scleral buckling, so basically stage 4A, stage 4B, and select eyes of stage 5 where you have only peripheral traction, anterior disease, where if you want to do vitrectomy, sometime you may have to sacrifice lens, and those are the scenario. Probably you still, I would prefer buckle once in a while, though we are doing less and less scleral buckling nowadays. And also another group will be late onset RDs. That is out of scope for this discussion, so I'll leave it right now here that way. So the goal of this buckling here is to reattach the retina and to halt the progression of stage 4 going into stage 5B or stage 4B or stage 5. The exact mechanism still we do not know, but what we know is once you reduce the vitreous traction, this traction itself sometimes is a stimulus for reproliferation, which also reduces, and over a period of time, probably subretinal fluid get absorbed, RP pumps is functional, and retina reattaches. So technique is not much different as far as our conventional scleral buckling in adults, limbal 360 reopening, muscle tagging, and cryo or laser is done if you feel disease is still active and you have a peripheral or vascular retina available to treat. Basically, purpose here mainly to relieve the traction. Now, various options as far as 240 band or even 40 band or 42 band can be used, or sometimes segmental buckle also we can use, just if it is a localized area of cold retina or there is a traction and other quadrant if retina is okay. So you can either use scleral tunnel to have your encircling band going in, as you see here, or you can use the anchor suture. That's a lower picture, what you see. And band ends can be tied either with a suture or clovage knot, or can use a Watkins sleeve. So problem here is achieving buccal effect because eye is small, volume is less. Most of the eyes, though select group of eyes, we can still drain subretinal fluid, but most of the eyes you cannot drain. So probably you need a repeated paracentesis to achieve desired buccal height. And at the end of the surgery, always check optic nerve perfusion before you close the eye. So that is as far as surgery part is concerned. But what other additional issues you need to look at it? Also, you have here complications all related with general anesthesia and scleral buckling. We have to explain to the parents. And difficulties again here is sclera is extremely thin, muscles are thin, so you have to be extremely gentle. You have a orbit is very small, so placing buccal element, again, there is not much enough space. And when you tighten the buccal, there is a high risk of ocular ischemia. With the buccal tightening, which pushes the lens iris diaphragm forward, and already shallow angle, sometimes these eyes can go into ankle closure glaucoma as well. So you have to keep monitoring for that. and also for a vital signs, at least next 24 hours, because there is incidence of apneic spells. So close monitoring is necessary for disease, and obviously we'll need to plan a removal of, particularly when you use encerclage, removal after 6 to 9 months, because of otherwise your constricting effect, it can hamper growth of the eye overall. So coming to vitrectomy is technically one of the most challenging and difficult problem in VR surgery. Previously, there was the option we used to do open sky vitrectomy, but we won't do anymore. So generally, it's a closed vitrectomy with or without lensectomy, or you can add on scleral buckling to support additional peripheral area, particularly when you try to save the lens. So vitrectomy directly helps to relieve the tractional component and stop the progression of the stage 4A going into 5RB. So basically, where to make sclerotomy? When you look at it, you do an examination on the table and look at the peripheries, depress and see this stretched ciliary process, and probably this is not a good place to look at it. So have a clear zone and then choose where you would like to make your sclerotomy, enter the eye, probably open the conjunctiva and enter the just behind the limbus. That can be one way of looking at it. Or other option is probably you can go either straight to the clear cornea or through the limbus, depending on how anteriorly retina is pulled. So every case is different, and choose your location of the sclerotomy. And not only that, conventional 3 locations, depending on the quadrant of involve or meridian involve, you can change the location of your sclerotomy. Clock meridian also can be changed, whether all nasal or temporal, and in the different areas as well. As far as, yes, previously we used to do 2 port, but we realize using visco as a tamponating filling agent, but sometimes it keeps on leaking and recurrent hypotony. So AC maintainer definitely help to better intra-op IOP control, and that's why better hemostasis during the surgery. And particularly this, again, I'm talking basically here stage 5 ROP when you're dealing with these eyes. Pupil, quite sometimes lot of synechias are there, doesn't dilate. So either you can use iris hooks, or if pupil is flappy, atrophic, probably you can do a sector irectomy between 2 sclerotomies here. Only problem with the iris hook, when you use, there is sometimes post-operative, there are a little bit of a higher incidence of intraocular inflammation because of stretching of the iris and handling. And not only that, sometimes this pupil is flabby, falls back, and we have lost the cases later on because iridoretinal adhesions at a later date, and that prevented retina from settling down. So whether to start periphery or center, again, it's case to case. Typically, what I prefer to start at a center, linear cut, and then across, and then go to periphery. But if you have a gap in a periphery, that first video, as you are seeing, if you have a space, you can create an opening there. Once you achieve plane, your circumferentially eye, you can go around the periphery all 360 degree, and then approach the posterior pole. So either way, again, each case, depending on where you get the space, you have to be opportunistic. And wherever you are placed, and once you create clearance, then you just clean the central part. This is a persistent hyaloid system coming out, as you see the second video, and there your surgery ends. You have a relief traction to some extent. Next to that, you have a trough open gap you see on the temporal side and central part. So you don't aim at the reattaching retina on the table. You need to give time. Over a period of time, probably retina will settle down, but what you aim eventually as settling the posterior pole. If you get entire retina attached, probably you are lucky enough. And this is what typically you see, though technically surgery, you feel great when you end the surgery. But as you see, retina is attached, but top picture, but all the vessels are sclerosed. And then various pattern of so-called successful reattachment retina. But you know, overall, all these eyes, you can see atrophic retina, pale disc. So functional outcome probably is not that great. And that's exactly important thing to discuss with the parent before you take the babies for surgery. Coming to the lens sparing vitrectomy, the biggest advantage is you may get a chance to reattach retina because you are intervening at early stage. Posterior pole is generally healthy in these eyes, and because this is a time critical for a visual development, and lens is a integral part of visual development. So saving lens at this time, overall functional outcome is definitely better in these eyes. So choice of a gauge for a surgery when you plan about lens sparing. Again, there are no specific guideline, but surgeon's convenience, comfort, and availability of instruments are the most important factor, I would say. And again, you have more extensive dissection. Probably you use a less flexible instrument, that's the way it goes. And generally 27 gauge probably may not be ideal, particularly when you have a lot of fibrous stuff membrane at a periphery, 12 o'clock area, you would prefer 25 or 23 gauge in that scenario. Now, palpebral fissure is narrow. So, though sclerotomies are need to be made little bit anteriorly, and because of narrow fissure, sometimes it's difficult to accommodate all sclerotomies, but you have a working field is very significantly compromised. Again, sclera is extremely thin, so practically two-step or angle incision really does not work. Invariably, you will end up having a uniplanar incision, and you have to ensure that you enter your instrument more parallel to the visual axis so that you do not damage the lens. This visualization, obviously, you can use a wide angle visualization system, conventional, or you can see there comparative what you see through the Lander's lens, small area, and this is the same eye on the right side. You are seeing, sorry, left side, where you see a wide angle when a biome is used. So see, you can make out the difference. Just comparatively, I just took that video to understand the difference between two. You get a small contact lenses as well, because this biome are recite when you use, because wide diameter sometimes you can, because of smaller corneal lens, cornea, and your sclerotomies are closer, sometimes you can keep on bumping against the contact lens, non-contact lens, and that's why you have a smaller lenses available if you want to use. So basically, different tractional forces you add. Answer is the most important in anteroposterior. You are seeing this just behind the lens, showing this stalk. You are removing fibrous tissue, retrolental, and then the same eye vitrectomy showing that which is you keep on cutting going posteriorly and removing the vitreous. That's really you relieve anteroposterior traction as you cut that stalk, and this retinal fold probably will remain. You may not able to release fully, and the other you have a traction from ridge to the aura. Selectively, you ensure that you cut that one. You have a disc to the ridge. There is also a component of ridge to ridge, across to ridge from nasal to temporal side, or 1 degree apart. So each component you have to release if you want retina to be attached. And obviously, because you want to save the lens, probably you don't want to go across the lens, so better sometimes change the hand and complete your dissection as well. So yes, IVTA helps to some extent to not only have a better debulking of the vitreous. So most of the time, I mean, you are lucky enough, you are able to induce PVD, like you see second video here in the right side. So, but if you can induce the PVD, probably these are the cases do extremely well. Of course, you will not be able to detach fully, but sometimes you go up to beyond the arcade. I think that's more than enough. But as you see left side video, even if you do debulking and you put the because vitreous is most of the clear. So if you add a tricot, probably you see much more vitreous. You can do a much cleaner job, even though you may not be able to induce PVD in these eyes. So, but yes, the better vitreous you remove and final outcome. And these are the cases. It's a pre-op photograph and post-op photograph. The post-report looks quite healthy compared to what you saw in the stage 5 pictures earlier. Bimanual vitrectomy, as we do in a diabetic with MIVS now, with a smaller instrument and with a multifunction instrument. This is the infusion and combined light pipe here. So 3-port, the first left video is a bimanual with a 4-port chandelier we use. So like a diabetic, it is possible now to do combined like a bimanual vitrectomy, even in a small ROP eyes. And you can see like a massive proliferation here. And this is a relatively reasonably good post-op outcome when you use a bimanual vitrectomy. Of course, Avastin was in that case. And this is another case where you have a peripheral traction here, and then you have a central traction. So central part is removed, bridging traction was removed, and periphery, I wanted to save the lens. It was supported with the scleral buckle. These are again the rare scenarios. As we see, you see the periphery is pulled off. I didn't want to damage, sacrifice lens. Here, though we remove other video in the right-hand side, even though we remove the lens, the extreme periphery was pulled up significantly. And there was no way we could release that traction completely. So to have a more flattened macula, and this peripheral retina, we supported with a encerclage. This again few cases where there are practical difficulties. As I said, sclera is thin. You have low scleral rigidity. So while entering, you can have a collapse of the globes that you see here. It can sometimes be dangerous, and when you push through much, you may hit the retina if it is anteriorly elevated, or globe can keep on collapsing. And again, as you see, because of again thin sclera, very easy to have a slippage of the cannulas coming out during your prolonged surgeries. And sometimes it can be loosened. At another video, even infusion cannula is slipping off, and sometimes it just keeps keep on coming out. So you have to keep eye on it and see that your cannulas are very much in place throughout surgery. And particularly we are working in a dark, when the lights are off, sometimes very easy to miss that part. Here, typically what I would like to show is a long trocar cannula system we have, and where I just hit posterior hyaloid, created a whole round hole here. I was lucky enough that this retina I did not hit. Otherwise, the case is over during your sclerotomy only. So all these things you need to keep in mind when you're dealing with smaller eyes. We have availability of now shorter instruments. The advantages, they are small, shorter. That's why they are stiffer also. And yes, smaller infusion cannula, you have to see on the sclera. But yes, they definitely have a reduced risk of retinal lens damage when you're using this instrument. And also, because of their stiffer, you have better anterior approach when you deal with a peripheral. If you do not have, while making this sclerotomy, you can have existing instrument. Partly what you can do to enter it through, and once negotiate the sclera, then you don't go full length of your blade. You hold the blade in place and push only cannula inside. That way also can helpful to manage or to avoid the damage to the detached or elevated retina. So we can have existing one, and Dr. Naresh Babu has nicely explained. He has put a bit of our band, like a encircling band, belt buckle, a bit of that's creating as a bolster like thing, and pushing over the steel blade or cannula. That also sometimes prevent the entry or full length you are going inside the eye. So yes, proximally placed sclerotomy and cannula system does not allow easy access to the 12 o'clock area, vitreous around the sclerotomy or anti-tractional retinal fold. So what you can do sometime like a conventional 20-gauge sclerotomy, what we used to do here, instead of using trocar cannula system, you just direct blade, create through the sclerotomy in the sclera alone, avoid the cannula at all, so that this extreme periphery, what you are seeing, can easily approach using the same 25 or 23 gauge instrument. So that way you can better approach and better relief of the traction you can achieve. So to conclude, in eyes with advanced ROP, vitrectomy forms an important surgical intervention strategy. Lens sparing vitrectomy helps achieving potentially useful accommodative vision at a critical period of visual development. ICOT offers the benefit of better visualization of vitreous and has better release of the traction. And shorter, stiffer instrument offer better and safer approach to the peripheral retina. With MIVS, multifunction instrument, and bright illumination sources, more complicated surgeries can be performed using this biomanual technique. So thank you very much for patient hearing. And once again, thank you. Thanks to TNOA and entire team for having me here. Back to Parag.
Yeah, thank you, sir. Any questions from anyone? Okay. Thank you, sir. Wonderful videos. And Dr. Rajkumari, can you introduce our last speaker, please?
I'll take that up, Parag.
Okay, good.
Gives me great pleasure to introduce one of my teachers, Dr. Meenakshi Swaminathan, who started her medical education in Madras Medical College in 1981, then went on to do an ophthalmic residency in VGI, then again in University of Louisville, Kentucky. Then she's a AAPOS certified fellowship pediatric ophthalmologist and has also passed the American Board of Examinations. But best of all, she's been teacher and guide and mentor to so many students in Shankara Nethralaya for over 2 decades, starting from 2006 up till maybe last year. And her special areas of interest include CVI, adult strabismus, and ophthalmic education. So I thought there would be no better person to talk about all the effects of ROP, which we generally turf off to our pediatric ophthalmologists, in my case, my spouse. So which we happily not worry about, but I am sure that's a very, very long and vast thing. I thought Madam is the best person to talk about it. Thank you, Madam, for accepting the talk.
Thank you so much, Sriram. And I did ask Sriram, hey, why don't you ask Supraja only to talk? And then he just went quiet. So I said, okay, maybe that's an area we'll not get into.
And she asked this question to him.
Yeah. So thank you so
Sir,
much.
I want to talk, so it'll be a lot of complaints then.
So it's so wonderful to be here. I'm always in awe of all you retinal surgeons who do such wonderful work, especially with the tough cases of these premature ROP children. I had a brief stint of doing in the US as part of a pediatric ophthalmology fellowship. You have to do the ROP screening yourself. So I was, doing it for a year and also in Essen for some time. So I know what an arduous task this is. So I kudos to all of you. I thank TNOA and all of you and Sriram for this very kind invitation. But I want to say all your hard work will not bear complete fruit if we don't step in, pediatric ophthalmologists, comprehensive ophthalmologists, and rehabilitate the child after you have done your work so wonderfully. So in the next few minutes, I'm going to cover this short but important topic on long-term visual rehabilitation of ROP. Now, most of these cases I'm showing here are all fictitious cases, and because they're not typical patients, so please don't wonder about the blonde hair and blue eyes, but they're just to take, make a point. So here is a typical 2-year-old child who holds objects close, goes close to the television. There is no family history of myopia, and the history is only of ROP treated with laser photocoagulation. And when we do a cycloplegic refraction, it shows a significant myopic astigmatism, myopia of -4. Now that's, quite a bit in a child with no family history and, is not a school-going age. So then you realize that this is a different entity that you're going to be dealing with. So what is going on and what do we call this? Yes, it has a name and it's called myopia of prematurity. Now, what do we mean by that? So if you look at this, it basically it occurs in all the following. You have the ROP treated by any modality. You have children who have spontaneously regressed ROP. And you also have prematurity kids whom you followed who never developed any ROP. All of them have a higher incidence of myopia. And how do we know this? We know this thanks to the cryo ROP, the ET ROP, and the beat ROP, which looked at these kids prospectively. What does the data say? So if you look at the data, the cryo ROP kids, even the kids who did not have any ROP, had myopia of 21% at 1 year. And those, of course, with severe ROP were significantly, number was myopic, which is 80%. And look at that, almost half of them were high myopia. And the same story repeats in the ET-ROP study. Again, a significant number, despite the early treatment, were myopic and high myopia. And if you look at the beat-ROP, which compared the laser with the intravitreal bevacizumab, again, high myopia was present in both groups, but high myopia was 50% of patients of laser group compared to 22%. So there seems to be a higher incidence of myopia if you laser these kids, especially high myopia. So, of course, I'm sure even all vitreoretinal surgeons are all very familiar because almost all of us have kids who are wearing glasses. Of atropine, low-dose atropine and these special lenses, do they all really work? Well, this is the interesting thing. This myopia of prematurity has a typical bilinear pattern. It seems to start in the first year of life as an infant. And this is because of increased corneal curvature, a thicker lens, and a shallow AC. It is not because of increased axial length, which is what we look at as the etiology for progressive myopia. In fact, for the given diopter value, their axial lengths are shorter. So the understanding amongst the pediatric ophthalmic community is that the low-dose atropine will not work. Having said that, some of us still, when we find progression, we monitor axial length, and some of them are treated with low-dose atropine. But it's important to remember the etiology is completely different. So let's then conclude this by saying the bottom line is that these kids have a very high chance of high myopia, which starts in infancy and seems to be more in laser-treated kids, and the abnormalities appears to be in the anterior segment. Okay, so we move on to a second case, which is a 13-month-old baby born at 30 weeks of gestation, and the birth weight is 1.1 kilogram, again, laser photocoagulation done for ROP, and was noticed to have an esotropia at 4 months of age. So what do we know about strabismus in premature infants? And again, this is a fantastic publication from way back in 1998, part of the cryo-ROP study publications. And in that, it showed that even at 3 months, already 6% of kids showed strabismus, and this number doubled by the time the child was 1 year of age. Now, or 12 months of age. The presence of strabismus at 3 months was a strong predictor, a significant predictor of strabismus at 12 months. There were a few other factors as well. Abnormal fixation, anisometropia, unfavorable retinal structure were also important predictors. Of course, through the years, we have gained more and more knowledge about strabismus and refractive errors in these kids. So this again is an early 2000 publication and a pretty good group from Netherlands. And they looked at kids both under 32 weeks of gestational age and more, and they called it the prevalence of SAR, strabismus, amblyopia, and refractive error. And they found, of course, the younger kids definitely were at a higher risk, but this seems to be associated with gestational age, duration of supplementary oxygen, duration of hospitalization, were, say, predictive factors. And they threw out some, recommendations for follow-up. So they said, if you have kids who are less than 32 weeks of age, gestational age, you have to screen them at 1 year, 3 years, and in their country, of course, they start school at 5, and again at 5 years with a proper opted type acuity. Now, let's look at a few more studies which looked at this area of strabismus. This is again a very good study published in 2014 in JAMA. It looked at effect of gestational age and birth weight as independent risk factors. And they found that the very low birth weight conferred a large increase in strabismus risk among premature patients. So we are now, slowly starting to list out what all present in a premature infant makes them at higher risk for strabismus. One other study from the Deborah Van der Veen group, and this is a very important multi-center LGAN study, which is extremely low gestational age newborn. And what did this study find? This study found that the overall prevalence was about 14% at 2 years of age, and the vast majority of them seemed to be esotropic, like you saw in the picture that I showed before. And again, significant risk factors were birth before 26 weeks of gestation, severe fetal growth restriction, maternal history of aspirin ingestion, and then a few other postnatal factors such as, a SNAP score of a certain value, brain ventriculomegaly, which is often picked up on ultrasound, type 1 ROP, and ventilator-dependent severe bronchopulmonary dysplasia. So it kind of seems like a very young kid, born very premature with a lot of other comorbidities, seems to be at a high risk for developing strabismus by even 2 years of age. So the bottom line is that strabismus can develop early in infancy. Several risk factors have been identified, especially birth weight, low birth weight, and low gestational age, and esotropia seems to be most common. Now we move on to the last case, which is a case of a 4-year-old boy who was born at 28 weeks of gestational age. I didn't put the weight here, 1.3 kilograms, perinatal hypoxia. Developmental delay was noticed initially, but the child seemed to pick up, but later on was found to have difficulty with crowding, which means he couldn't identify his parents in a crowd. He could not pick up, things from a clutter. He had difficulty climbing up and down. He had problems copying from the blackboard, even though the vision recorded was 6/9 and the ocular examination was normal, because the blackboard presents a poor contrast environment. And so when a kid like that comes to us today, we know to start thinking about and especially in the setting of prematurity, we start thinking about periventricular leukomalacia, and this is what you see if you do an MRI. And so the diagnosis in this particular patient would be a cerebral visual impairment. And there is a lot of work going on in CVI in both term and preterm infants. Now, we would consider this person, Gordon Dutton, the father of, CVI, and he has a beautiful website called CVI Scotland, which is one of the very early publications on periventricular leukomalacia way back in 2000. And what does he say? So basically, the postulate is that the preterm infant has an immature, vulnerable visual system. And so when things go haywire, a child is born too premature, has a whole host of other issues going on at the time of birth and post-birth, the optic radiations are affected, resulting in periventricular leukomalacia and a clinical diagnosis of cerebral visual impairment. These kids may or may not have cerebral palsy, which means the motor deficits that you associated with CP, but they very, very often will have visual impairment, visual perceptual problems, crowding, as I told you, visual fields. These kids will stumble over objects. They will hit against objects. They'll have difficulty going up and down the stairs because their visual fields are also limited, also affected. So CVI in these kids born premature is another very important entity to keep in mind. So the bottom line is that CVI can be present in any child with a stormy perinatal course, and premature infants are at a higher risk, and it needs a high degree of suspicion. So I can literally hear the retinal surgeon saying, you know what, I have finished reading the ROP. Surgically, I've done the laser, I've done the vitreous injection, whatever. Or I've been following the kid and the kid is fully vascularized. Okay, now you tell me what should I do? And this is all great, all these fundas that you have shared, but what should I do? So I think you, being the primary surgeons, the primary clinicians that they have dealt with, you need to talk to the parents and tell them that the child is going to need a lifelong follow-up. So you send the child to a pediatric ophthalmologist or a comprehensive ophthalmologist who is comfortable with dealing with young babies to screen for squint at 3 months and refractive error and amblyopia by 6 months of age. You don't need to take on that burden. We will do that. And the CVI screening needs to be kept in mind when the child is ready to start school or the child is struggling in school. So in summary, prematurity and low birth weight are important causes of ophthalmological morbidities in children with and without ROP, and they need a lifelong follow-up. And I thank you for your attention and this opportunity.
Thanks, Meenakshi, for taking care of our babies. We operate happily and pass it on everything to our pediatric ophthalm. We were lucky to have a good pediatric ophthalm department, actually. We're really grateful to them.
And that is so important. I mean, like she said, we do a good job, but leave it at that. But if you don't have, and I've seen stage 5 ROPs well attached and referred back to me from Calcutta and coming here without glasses, the child can see. I said, come on, glasses has something, refractive error, and followed by a pediatric ophthalmologist is extremely important, for the child, of course.
If you're doing ROP, always ensure you have an in-house pediatric ophthalmologist.
Not everybody has lucky as you.
Yes, we are pacifying.
No, she's sitting right behind you, sir. That's why.
Any questions from the audience, Sriram?
None so far, Parag.
No.
No questions. Almost more than 50 of them have logged in, but no questions.
Okay. Anything anyone wants to add? Something?
This is Bala here.
Yeah.
I was speaking to Sriram also. This regarding, do you need a consent form even for screening? Because in the operation guidelines, I'm not sure whether I've read it about consent form for screening. Is there any consent form even for screening?
Some NICUs told us, at least one NICU I remember, but we don't take it. I mean, it's just a standard of care. So we don't take it. I don't know if Pramod sir has some other.
We generally take as a routine consent when they enter for any patient for examination. Yeah, not specifically for this screening, but yes, before screening, we talk to parents. Obviously, that is there.
Yeah. that what Dr. PV sir is referring to is a general consent, which any OPD patient who walks in, who signs,
Yeah, I agree.
like permission to be examined and if necessary, imaging, etc., etc.
Correct.
But I think the moment a baby is referred to your clinic for ROP, for your place for ROP, I think the clause of implied consent kicks in. Because the fact that they have this thing, but I think it is our duty to inform both verbally and physically. So what I practice is, one, before examining every baby, we ensure that we tell them that this is why we are examining the baby, and that will be because I always ensure the attenders sit right next to the baby when I'm examining. I don't want to send them out, because even if there's a small subconjunctival hemorrhage, you don't keep them in while examining, then they come back and complain it's a bigger issue. They don't know what you've done. So I ensure that the attenders are in the room while babies being examined. And I make it a point to explain why they are being examined, and I will be putting a speculum, will be restraining the baby will be crying, etc. And I also have a poster in the ROP waiting room on all what ROP is about. I also give them a pamphlet the moment they register. So they are pretty much prepared mentally. So usually when they are prepared, then there is no room for a mental shock. So these issues don't come up. Same with the NICUs also. One thing about these NICUs I thought was this ROP. This NICU always has a waiting area outside where those parents keep sitting 24/7 for weeks together. So if you generally put up a poster on ROP outside, so in the rare event, even if the pediatrician or neonatologist, it doesn't ring a bell for him to do an ROP screening for the baby. A lot of times I've seen babies attenders who the babies itself didn't need ROP screening, but they looked at some other babies having screening. So they were eager to have their babies' eyes checked as well. So that can serve as a public education message as well. So that's another thing we can do. Have a big poster put up in the NICU, in the waiting area especially.
Okay.
I have a question to all of you actually. So I'm just curious, at least in Tamil Nadu, do you see even now advanced ROP that has been missed, has not been screened, being referred to?
Yes, yes, Meenakshi.
Unfortunately,
yes.
Okay. Is there something that TNOA can do socially without stepping on toes of the neonatologists? Is that possible to even identify, whatever those, I'm sure these happen consistently in a few areas, a few nursing homes. Can we intervene in sense you have a pediatric conference, you have pediatric CMEs. So I think the message needs to go hit hard with the neonatologists. The parents are very, very important because they'll at least nag them and tell them, have you done the eye examination? But I don't know if it's equally important to also educate the PGs as they are preparing for, to become pediatricians, as they're preparing to do neonatology fellowships. Is it important to have a class or a session or something on behalf of TNOA on ROP? Just a thought.
I think it's happening through ROP task force. Also, Ministry of Health is and IROP, so like Indian ROP group society now also has trying to have a webinar, seminar, region wise, like a north, east, south, central, something they are trying to create. Also, not only neonatologists, it's so many times obstetrician, they themselves early stage, they take care of what you are talking about, like clamping your umbilical cord and all those things, prenatal, your steroids, everything. So even for them also awareness, the workshops are happening, and also probably is becoming slowly part of curriculum. It will come in the textbook also, that more about ROP. So hopefully combine everything will help overall to just create more awareness. We hope that country is big, each one has their own setup, their practical issues. Yes, Sriram.
2-3 things, sir. One, yes, the neonatologist bar pediatrician needs to be made more aware. We ophthalmologists, only to a certain extent we can go, but people like Dr. Srinivas, he can speak more on his forums and educate them. But I think they're doing a pretty good job. I think where we might be lacking, the way I look at things, is the NICUs are coming up very fast in very, very small places. But we don't have screening facilities in those places, and sending these cameras, though it might work for now, the rate at which the NICUs are coming up, I don't think it's going to be a practical solution. So my thought would be to make take the mental block out of general ophthalmologists and make them do ROP screening. I think that is the final solution, because end of the day, it is only indirect ophthalmoscopy. And as Parag very rightly mentioned in one of his slides, the only thing you need to know in ROP screening is plus disease. If you see a plus disease, refer. If you don't see a plus disease, follow up. I know it's an ultra simplification, but still, I'm sure Parag will agree with that. So that is all the general ophthalmologist needs to see. So it is not something which is very high-fi. And if somebody can diagnose diabetic retinopathy by looking and finding a microaneurysm, I'm sure they can find a line or a ridge and a plus disease, which is much more gross. It's more of a mental block. And our dear President, Dr. Ramakrishnan, actually initiated a idea of a short-term observership, wherein people would be able to go to some institutions, TNOA members to certain institutions, and spend time and try and learn. Now that Dr. Parag and PB sir is also there in the same forum, RK sir, I think, and RK sir is also there, I think we should start off this initiative wherein we can ask general ophthalmologists to come spend from small towns especially. I'm not talking about somebody who's a retinal surgeon in Chennai. He doesn't need an ROP exposure for 2 weeks. I'm talking about a small town general ophthalmologist. You bring him to some place, make him stay for a week or two, expose him to ROP, so that, let us say, like for example, Dr. Rajakumari is there from Tenkasi. I'm sure before she went to Tenkasi, there was absolutely nobody there who could look at the fundus of a neonate. So in places like this, if we pick up people and train them to at least see the fundus and refer if necessary, I think that will go a very long way. This is my 2 cents.
It's good. Really, it's a good webinar, Parag and Pramod. It's really a lot of learning through this webinar, a lot of new things. And as you mentioned, no, definitely we are thinking on that line also. Soon, within this month, we can send a message to all the ophthalmologists, those who are willing to, and also I am going to keep in contact with the leading institution like Sanganathralaya and other hospitals where they are doing a lot of ROP work, so that the nearby doctors can go. So I think it's 1 week, not more than that, because they may not be interested. More than 1 week is just to find out what is what. So that we help a lot. Yeah, definitely we'll do it.
Yeah, one suggestion is that maybe TNOA can now approach the IAP, Tamil Nadu chapter, and in their conferences have a joint session, like,
Yeah.
in their state conferences.
Yes.
Invite them also to have a session in the TNOA conference. And tell them also to invite.
There was a talk on ROP in Trichy, recent South Neocon, which took place 6 months back, and there was a talk on ROP, and they do have this.
Yeah. So it should be like a regular affair, They should also be equally important to be given. Like you said, primary prevention is so important, and it can really reduce our burden dramatically.
You can have a pediatric ophthalmology session where, like you just said, and ROP can be one of the topics. And, and like you said, you constantly give the message over and over again every year, then it's finally, it sort of, gets in.
And those IAP conference, even the PGs will be there, obviously.
Yes,
the
absolutely.
PGs. So they also will be a good.
Yes.
Thank you.
Thank you.
Basically, more of
24th, we have a guest lecture on glaucoma by Dr. Devendra Grover from USA. We'll be giving a talk on GAT, that is gonio-assisted transcranial trabeculotomy. What is new? I think you can pass a message to all your juniors and so that they can attend. So Ram, what's the time? Almost 12:40.
Lot of thanks. Big thanks to our beloved president. Actually, you will be knowing that this webinar has been in the blocks since November. But we've been having successive webinars and other physical meetings successively. So we wanted to have it on a properly without anything else close by on a Sunday morning, devote 2 full hours to it. So that is why we had pushed this until February. I'm very happy we did it because we had a very relaxed webinar with very good attendance, and we had an array of speakers here. My sincere thanks to our beloved President, Dr. Ramakrishnan, for making this happen. And my next thanks goes out to two of my teachers, Dr. Pramod Bende and Dr. Meenakshi, for having accepted and given their talks in this. Thank you, sir. Thank you, ma'am. Thank you so much.
Thank you. Thank you.
And my next thanks goes to my beloved buddy and my friend, Dr. Parag Shah, who I've seen as a co-PG and a classmate, and a lot of things I cannot tell here what we did when we were doing our PG, but somebody who I've seen grow so much in stature that whenever I look at the ICROP classification, I feel proud that his name is there. He was one of the people who was there in the committee. So I feel so proud of him. Thank you, Parag. Thank you for wonderfully coming up with this agenda and selecting the speakers. I also thank the other speakers, Dr. Bala, who willingly accepted to do this, because I really wanted a primary care person's purview on this ROP screening, which is usually always delegated to a tertiary care support level, and only institutes do it and stuff. But Bala has been taking it up in his place and doing it in such a good way. Thank you, Bala. My special thanks to Dr. Janani, Dr. Renu Rajan, and the other two moderators, Dr. Syed and Dr. Rajkumari, for spending their time and giving their wonderful inputs. My special thanks to our sponsors and technical support people, INTAS, and Mr. Sham, the representative of INTAS, who's online. Thank you, Sham. Thank you for making this happen. And the last thanks to all the delegates who are online. And thank you so much. Thank you for sparing a Sunday morning.
Thank you.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you. Thank you very much.
Thank you, everybody.
Thank you, doctor.
Thank you. Thank you.